But we will continue with next session. I invite Dr. Atul Patel.
So good afternoon, everyone, and thank you once again for inviting me to speak in this ID conference. So I'm going to speak on endocarditis. The main important challenges lies in the making a diagnosis, and of course, management part we have already discussed since yesterday. So we'll just touch upon. So traditionally, when we talk about the infective endocarditis, we believe that it's a cardiological problem or the infectious disease or the internist are looking after this. But remember that the infective endocarditis patients can have systemic as well as the local cardiac complications, and which brings them to the ICU and requiring ICU care. And there are so many the conditions associated with the endocarditis which can bring your patients into the ICU, like the patients may require vasoactive therapy, advanced cardiac monitoring, organ supports because of the shock, and the acute heart failure leading to the pulmonary or the respiratory support. So all these things can occur in a patient with endocarditis, which brings them to the intensivist. Now, what are the important the challenges, especially in the diagnosis? The main important diagnostic challenge in the endocarditis would be like the clinical presentations in most of the patients are entirely non-specific. So from the presenting illness, you are not going to make a diagnosis of infective endocarditis. Most of these patients they have already received the antimicrobials, and because of this, like, you may not get a positive blood culture which can be a clue to the endocarditis. And the echocardiography, because most of the time the transthoracic echocardiography was done to the for the assessment of the patient's cardiac conditions, and we know that it has several limitations to pick up a diagnosis. So all these three important diagnostic parameters, like the clinical presentation, the cultures, which is probably the laboratory diagnosis, and the imaging diagnosis, that is echocardiography, all have several limitations. So our job is to suspect endocarditis, right? So this is how, like, you can pick up the case of endocarditis. So how do we suspect? So whenever you are dealing a patient who has genuine pyrexia of unknown origin or the fever of unknown origin without localization, so these patients are having the high grade or the fever which is running without any organ dysfunction. So patient may not have any cardiopulmonary, patient may not have any GIGU or the musculoskeletal pain. So no organ has been involved with this febrile illness, and patient is just spiking fever. So whenever you encountered a fever without localization, and this patient has cardiac risk factors for endocarditis. So I think these are the two very important clinical conditions where you can suspect that these patients could have the underlying endocarditis. So when patients endocarditis is progressive or the virulent organisms is responsible for the endocarditis, then you are going to get the cardiac complications, right? And when patient is having a local cardiac complications and plus or minus embolization, then it becomes very easy for you, because with the cardiac complications like chorda tendini rupture, valve perforation, valve rupture, you will get sudden cardiac failure with the large loud murmur. So this will also, tell you that this patient could have endocarditis. So this is from the history, but the physical examination, I think this is very important for us. And as a clinicians, I think, you are going to pick up all these important, the dermal stigmata of endocarditis. Remember that all these features are not seen in 100% of the patients. Only 20% of the patient will have this type of dermal stigmata or the of the endocarditis. Out of this, the Osler's nodes are the immune phenomena. So these are the painful, the raised the papules. Generally, they are tender. The Genway's lesion. These are the Genway's lesion from one of my patients. You can see that there are red erythematous patches over the palm and the sole. And you can also document or demonstrate the splinter hemorrhages. But for all these dermal stigmata, you have to examine your patients carefully. Just look at the nail just to identify that whether there is a presence of splinter hemorrhages or there or not. Look at these erythematous patches, which is Genway's lesion. And this is how, like, you can make a clinical diagnosis of possible underlying endocarditis. Now, what are the underlying cardiac conditions? which is probably we are looking for in a patient who has pyrexia of a known origin. So those patients who has a past history of endocarditis, this is one of the very important the risk factor that this patient could have this fever because of the recurrence or the relapse of endocarditis, right? So past history of endocarditis or the previous endocarditis is one of the very important factor. Apart from the prosthetic valve or the prosthetic material that has been used, IV drug users or the patient who has a staphylococcal infection, these are the conditions where you can suspect that this is a high risk factors for endocarditis. The other the risk factors would be a prosthetic valve or any the prosthetic material that has been used to repair the valve or the transcatheter placement of the valve. So all this the foreign body or the hardware inside the heart is also as a risk factors for endocarditis. The patient with congenital heart disease, ventricular assisted devices, they are also in a significant risk for endocarditis. The intermediate risk for endocarditis are the rheumatic valvular disease, the patient who has a degenerative non-rheumatic valvular lesions like calcified bicuspid aortic valve or something like this, and the cardiovascular implanted electronic devices like all the pacemakers and other things. The hypertrophic obstructive cardiomyopathy is also one of the risk factors for endocarditis. Now, when you are dealing a patient who has received an organ transplant and you are suspecting endocarditis, then most of these endocarditis in these organ transplant patients are a nosocomial one. And those patients who has received a cardiac transplantation, the Aspergillus and the Staphylococcus, these are the two very important pathogens. Both are nosocomial and they occur generally early during after the post cardiac transplant. While in other solid organ transplant, the staphylococcal infections is very common. So this is how like you can suspect from the clinical history, from the clinical examination. But how do we confirm a diagnosis of endocarditis? This is very important and tricky. And for this, you need an endocarditis team in your hospital. Just like when we are making a team for mucormycosis treatment. So we have surgeons, we have clinicians, microbiologists, radiologists, all are supporting each other to make early diagnosis and treatment of mucormycosis. Similarly, for endocarditis team, you need a cardiologist, cardiothoracic surgeon, infectious disease or the any internist is fine, and the microbiologist, right? And this multidisciplinary team is required because it will help you to reach to the earlier diagnosis and accurate diagnosis. Accurate diagnosis is very essential in the making a management of endocarditis. So apart from this, like all these team members will help you for a treatment decisions like when to operate this patient, when to not operate, and when to do a valvular repair or simple vegetectomy. So all these important treatment decisions probably this team will carry out. So let me take you to the case how this team is very important in the management of endocarditis case. So this is a 67 years old farmer and he was retired since last almost 30 years, and he was well before 3 months, and he has off and on fever since last 3 months. The maximum fever spike was up to 101 degree, and lately he has started getting dry cough. So these are the only two symptoms that patient has. He has type 2 diabetes since last 15 years, high blood pressure, ischemic heart disease PTC in 2013, prostate surgery in 2015, and he had CRT implantations for dilated cardiomyopathy before 2.5 years. So after this CRT implantation, he had surgical site infections and the lead displacement, and which requires a replacement at other place. And the pouch infection was controlled with some antibiotic, and he has nice response. So since last 2.5 years, like he was doing perfectly all right, except like he has started getting fever spike and some dry cough. So his recent laboratory workup showed leukocytosis, 81% polymorphs, platelets were 29,000. This is a recent drop in the platelet count. CRP was almost 8 times upper level of normal. Renal functions were slightly deranged, and CT scan was done as a part of fever workup. And you can see that it is showing some nodular lesions at the left base. So the galactomannan was performed and it came out to be positive 0.91. So remember that, whenever you are doing a serum galactomannan in a non-neutropenic patient, you should be extremely careful because the functioning neutrophils will generally take away the galactomannan from the circulation, and you are not going to get a positive galactomannan. So think for some false positive issue in this case. Whenever the non-neutropenic patient has the positive galactomannan. And if you overall look at the sensitivity and the specificity of galactomannan in making a diagnosis of invasive pulmonary aspergillosis, when you remove the neutropenic patients from all the meta-analysis, it will be around 30-35%, right? So sensitivity is very poor to reach to the diagnosis of invasive pulmonary aspergillosis. And the second important thing that we should remember as a clinician, that whenever you are looking at pulmonary nodular opacities, there are several other causes apart from the invasive pulmonary aspergillosis. So it's not only IPA, it could be anything, right? Even simple mycoplasma infection can give you a nodular or the clusters of the nodular infections pattern on the CT scan. So there are several causes which can give you a nodular the pattern on CT scan, right? So it's not that easy to interpret that nodules and galactomannan positive in non-neutropenic febrile patients. It's not that easy. His most recent transthoracic echocardiography 1 month back was absolutely normal. So during that time also he was spiking fever. So coming to my case. So he has genuine pyrex of unknown origin crossing more than 101. And he has intermediate risk for endocarditis because he has implanted cardiac device, like he has lead inside for the pacemaker. The pulmonary nodule with galactomannan, we have already discussed that it's not that easy to interpret whether it is the false positive or it's a true aspergillus infection. The blood cultures that we have collected on the admission remain sterile. So because of this intermediate risk, we look for the transthoracic echocardiography, and it was reported as the two AV valves. There was a large 20 by 21 millimeter vegetation over the tricuspid valve, which is bobbing in and out, possibly of vegetation attached to the RV. Lead cannot be ruled out, and there is a mild TR, right? So even though the echo was normal, the transthoracic echo was before 1 month was normal, but the esophageal echo picked up a very large vegetation. You can see that it is 20 millimeters or 2 centimeter size big vegetation. Now here the endocarditis team plays a very important role, like what to do with this patient, right? So if you look at the Duke's criteria, we are going to discuss about it, but we have only one major criteria, the typical vegetations which is demonstrated on the echocardiography. So imaging is showing, so there is only one major criteria. Minor criteria is a fever, but still we are lacking some other minor criteria also. So when we saw this, like we just, change our antibiotics to ceftriaxone, and because he has positive galactomannan, we have added voriconazole. And obviously, like large vegetation, galactomannan positive, some pulmonary nodular infiltrate. So we thought about the surgical management. So we discussed amongst the cardiologist and CT surgeon. So cardiologist was little bit worried about the low platelets, but though the platelets started improving within a week time, like it has reached to the 100,000, and the patient was a comfortable patient, was not having any mucocutaneous bleeding. So platelets gradually improved after this antibiotic and antifungal therapy. But cardiologist was little bit worried, and he said that probably if we try to pull out this the leads, it may damage the vessels. So it is not possible. And CT surgeon, because of the dilated cardiomyopathy, once we remove the lead, like how we are going to manage this dilated cardiomyopathy part, because this patient requires the CRT machine. So ultimately, like when we discuss with the patients and patients relative, and they agreed for the open heart surgery, and because this is very risky for a patient who has dilated cardiomyopathy. So we have removed this the CRT lead through the open heart surgery, and we planned a vegetectomy if the tricuspid valve, the rest of the area looks good, or plus or minus valve replacement for tricuspid. And look at this. This is the surgical sample. The entire lead that was removed during the operation, showing a very large vegetation. This is the postoperative specimen. And look at the histopathology of this vegetation. It is a fungal ball, right? So it is full of aspergillus fungus, and the flavus was grown in the culture, and the patient was managed, because now very difficult to put the intraventricular the leads because of the recent infection. So this patient was managed with the epicardial leads, and the CRT machine was replaced into the abdomen, right? So this is how, like, it was a collective decision between the infectious disease cardiologist and the cardiothoracic surgeon that we can incorporate the different management parts, and we have successfully managed this patient. So making a diagnosis of endocarditis in ICU, the message is that you have to keep a high index of suspicion. Like, even though the patient has intermediate risk, we have look for this, and always keep a low threshold for investigations. So get it done. If you do not have alternative diagnosis for this prolonged fever, and patient is having some risk factors for endocarditis, please get transesophageal echo rather than relying solely on the transthoracic. Look at the size of the vegetation. Even the operative sample is showing a very big the infected mass. So what are the important other common clinical features like of endocarditis? So the fever, the cardiac murmurs, which is very common in most of the patients, almost 2/3 of the patients will have the murmurs, and the patients, plus or minus patients, can have congestive heart failure. Few patients, they directly present with the embolic complications, right? So almost 1/4 of the patients, they have embolic complications, and the local complications in form of conduction abnormalities, various degrees of the heart block are also seen in around 10%. The peripheral, the skin, the classical stigmata is seen around 20% of the patients that we already seen, and many of the patients, especially the elderly and the immunocompromised, they have highly atypical presentation. They may not have fever, they have some constitutional symptoms, right? And these endocarditis patients can have either fulminant cause, so acute and rapidly progressive, and destructive wall lesions producing severe congestive heart failure, shock, and going to the ICU. Or patients can have the slowly subacute phase, like this patient who has 3 months history of fever, and patient was ongoing even with the large vegetation. And we know that, I mean, aspergillus, and that's the reason that patient was having positive galactomannan. So when we talk about the embolic risk and the patient's initial presentation with the embolism, so generally the patient who has a large vegetations more than 10 millimeter, preferably more than 15 millimeters, they are having a highest risk of getting the embolism. And look at this, my patient has 20 millimeter, and it was in the right side of the heart. So that's the reason that that pulmonary nodule was from the embolism from the infected cardiac lead. This embolic risk is highest with when you start antimicrobial therapy. At the same time, like a patient will have the embolism, and once the patient completes at least 2 weeks of antibiotic therapy, the risk reduces significantly, right? And the abdominal organs are the most commonly involved with the embolization from the cardiac endocarditis, like spleen, kidney, mesentery, liver, peripheral arteries, and the neurological complications from the left side of the heart with embolization is also not uncommon. So these are the criteria that I think I will highly recommend you to read this the article to make an accurate diagnosis of endocarditis. Right, in this revised criteria, they have included additional imaging criteria as a part of major criteria, and they have also included the serological criteria for making a diagnosis apart from histopathological criteria or the surgical criteria. The minor criteria remains the same, like predisposition. So this is very important. So my patient, if you look at the endocarditis according to this guideline, one major the criteria that was the large vegetation, the second was the predisposition, and third was fever. So one major and two minor. So my patient does not have the confirmed endocarditis to begin with, right? But when I operated this patient, and if I add the surgical criteria that he has vegetations and it showed the aspergillus, histopathology showed aspergillus, then it becomes a confirmed case of, or the definite case of endocarditis, right? So two major criteria or the one major and three minor criteria are generally considered for making a definitive endocarditis diagnosis, and the one major plus one minor or the three minor are considered as a possible endocarditis. So please read this manuscript very clearly. So general laboratory features of your endocarditis patient would be like To make a diagnosis, you should get at least 3 sets of the blood culture, and you are going to grow these standard organisms which are a part of definitions of major criteria, that are Staphylococcus, Streptococcus, Enterococcus, and a set group of the organisms. The prosthetic materials in patient who has prosthetic valve or the prosthetic material inside the heart, then the cones, Pseudomonas, Candida, NTM, and Cutibacterium. These are the additional organisms which is considered as a typical organisms for endocarditis in a case where the patient is having prosthetic material inside. The blood culture negative endocarditis, the serological criteria are also included into the major criteria. So you can also look for the Coxella or the Bartonella serology plus or minus molecular test to make a diagnosis. You can also get the elevated inflammatory markers, and urine examination will show you the sediments, microscopic hematuria, and you may get immune phenomena in terms of false positive rheumatoid factor. This the additional imaging criteria that has been included in this modified Duke's criteria are, they also look for the PET-CT evaluations in the making a diagnosis of endocarditis, and the usefulness of the PET-CT is mainly restricted to the patient who has prosthetic valve endocarditis, right? So in prosthetic valve endocarditis, the sensitivity is pretty good, 86%. The reason is that, like, you will get the glow around the infected area, so the tissue will be having higher uptake and it will glow up, and the specificity is also 84%. So roughly for prosthetic valve endocarditis, you can, even though, like, I mean, sometimes you may not be able to pick up the perivalvular abscess or perivalvular the some complications on echocardiography, but it can be picked up on this imaging like PET-CT or the WBC single positive emission scan. But for native valve endocarditis, if you are using PET scan, then the sensitivity is much less, because the main area of involvement or the lesion is in the tips of the valve. So you are not going to get the PET positive features over here. But mainly all these the imagings are used for to just assess the periprosthetic complications of patient with endocarditis. Now coming to the second part of the talk, like how do we manage? So the successful management of endocarditis relies both on the medical and the surgical therapy. So I used to tell my students that, I mean, endocarditis is not a simple medical case, it is a surgical case, because you have to have surgery for most of the patients, where you have to, I mean, go for the source control. So your antibiotics that you are going to use will be eradicating the organisms, and the surgery therapy will help to control the source, right? So it will remove the infected material and it will drain the abscess and take care of the source. So how do we select the empiric therapy? This is very important because the blood culture will take some time, right? So whenever you have major criteria which is supporting, like imaging criteria which is supporting your diagnosis, plus the rheumatoid arthritis factor is positive or the RF factor is positive, the urine is showing some microscopic hematuria, you have some skin lesions, which is, I mean, reaching a diagnosis of possible endocarditis, looking at the current evidence, then you have to put these patients on empiric antibiotic therapy before you get a final blood culture reports. So for native valve endocarditis and the prosthetic valve endocarditis, these are, apart from these two important factors which will give you a directions about the selection of antibiotic, you have to also consider the community acquired and the nosocomial, right? So these four factors are very important to select empiric antibiotics. For example, if you are dealing with some prosthetic valve endocarditis, then you are going to take care of the staphylococcus as a part of coverage. So ceftriaxone plus vancomycin would be the ideal empiric antibiotic for this condition. So generally for patients who are stable and responding well to your antibiotic therapy, 2 weeks of the parenteral therapy and the 4 weeks of outpatient treatment would be adequate. For prosthetic valve endocarditis, like more than 6 weeks of therapy is generally recommended, and for native valve endocarditis, 2 to 6 weeks. And this is also based on the first day of negative blood culture. For patient who has prosthetic valve or the prosthetic material in situ and patient has staphylococcal endocarditis, the addition of rifampicin is always recommended to take care of the biofilms. right? And daptomycin, like yesterday, the Parikshit told about, like you have to use a very high dose of daptomycin when you are using it for management of endocarditis. Now coming to the surgical management of this endocarditis, right? So again, your surgical colleague is going to decide, but the important indications for surgery would be the heart failure. So when patient has refractory or the progressive heart failure because of valve perforation, valve rupture, chordictentini rupture, or patient will have some perivalvular complications like abscess, conduction abnormalities. These are the situations where you are going to operate these patients on emergency basis. The another indications would be like failure to antimicrobial therapy. So when you have an uncontrolled infection, though we do not have a good definitions for this, but when you know the organisms, when you are giving optimal adequate antibiotic therapy for this infection, and patient remains persistent culture positive for at least 7 days of your appropriate antibiotic therapy, then this is the time that you should look at the source and try to operate this patient, right? So patient who has local complications, again, conduction abnormalities, rupture, perforation, so increase in the vegetation size. So all these are the additional the indications for surgery. And the patient who has embolization, so large vegetation, fungal endocarditis. So these are the patient who has a very high risk of embolization. And you know that embolization into the central nervous system or the mesentery can compromise the vital organs, right? So these are the patients who requires surgical therapy. So take home message from this, the challenges in making a diagnosis and management of endocarditis would be, we have to have a very high index of suspicion and low threshold for investigations for endocarditis in appropriate patients. Teamwork is required for early and accurate diagnosis as well as the successful management. So example I have given to you, and we have to use a diagnostic criteria, right, to make an accurate and perfect diagnosis of endocarditis before we bombard this patient with the diagnosis of endocarditis. PET-CT is a very useful tool for making a diagnosis for prostatic valve endocarditis, and duration of antibiotic therapy is different for prostatic and the native valve endocarditis. Thank you very much. So any questions?
Any questions? Post lunch, anyone like want to stand up? Please stand up. Stretch your legs, stretch your arms. Feel free to stay awake.
Sir, it's a very good lecture, sir. Just wanted to ask you one thing. Just like the RF factor being false positive in this, any chance of being the ANCA positive?
RF factor, like, I mean, we know that, I mean, RF factor is a false positive in a patient who has intravascular infection. So any patient who has intravascular infection, there are high chances of immune complex formation because antigen is also circulating into the blood and the antibodies at the same time try to produce against the circulating antigens. And this is the reason why we are getting false positive RF factor. Right, so generally, like ANCA or the MPOPR3 has not been used for making the immunological phenomena, and RF factor has been used as a minor criteria as a part of immunological phenomena in making a diagnosis of endocarditis. Yeah, so okay, so follow up of this patient. So this patient we have treated with voriconazole monotherapy for 9 months, and patient is still alive. So this patient was a pre-corona patient, and even after the 6 years, like patient is alive, so we have stopped voriconazole after, because we have successfully removed the source, right? And that nodule also cleared with the follow-up CT scan of the 3 months, and we have stopped antifungal therapy at the 9 months.
You were mentioning about IC bleed in the as one of the complication of neurological complication of this thing. And you separately mentioned mycotic aneurysm separately.
Yes.
So what's the mechanism of IC bleed?
Yeah, so what happens, like the intracranial complications are of two forms. One is from the embolization from the left-sided endocarditis, and the second is because of the circulating infections, circulating organisms, it will produces the vessel wall infections and produces mycotic aneurysms. So this mycotic aneurysm can rupture and produces the bleed into the CNS.
So no, IC bleed that you mentioned is a complication of the mycotic aneurysm.
It's a complications of mycotic aneurysms.
Suppose I have a patient, say I have a case who is diagnosed as infective endocarditis, after seeing a MRI showing multiple embolic infarcts. The patient came with some other symptoms. If we did an MRI, we have an MRI showing multiple embolic infarcts. We think of suspicion of IE is possible. We did a echocardiography, diagnostic was IE. Culture is also positive. At what point of time will you quick in for surgery?
Yeah, so here two points comes. One is we have embolization, so the patient is for surgery, and the second is like, I mean, because this patient could have additional mycotic aneurysm, and for the embolic complications, we are going to use the antiplatelet agents. This is very important decision. So again, here we need a cardiologist to take a decisions when to start the antiplatelet agents and when to operate, like how long we can stop the antiplatelets before we operate. But generally, when patient is having a major CNS embolic complications like multiple embolic complications, this patient should be taken as soon as possible for a surgical for the surgical therapy. Once the patient has achieved little bit of hemodynamic the stability, you cannot wait till the patient develops a complete or patient achieves complete hemodynamic stability, because I mean that you are not going to achieve because of patient is already having some dysfunctions of the valve or the perforations, right? So little bit of stability, looking at the platelets, looking at the presence or absence of mycotic aneurysm or plus or minus anticoagulant or the antiplatelet therapy, you have to make a decision that when you are going to take this.
Why do you want antiplatelet therapy here? Because
Yeah.
it's not an ischemic or it's not a thrombotic complication, right?
Yeah.
It's a
So-
vasculitic kind of thing producing.
So it's a multifactorial, but for a pure embolization, like we have to use the anticoagulants for treatment of these patients. But again, that decision is coming from a cardiologist, and that's the reason that the endocarditis team is required. So few patients, they will require additional anticoagulations for a little longer time. Not all patients. So it's again a delicate decision when to start antiplatelets, whether this patient requires the systemic anticoagulation or not, and when to operate this patient, because embolization becomes one of the indications for surgery. At the same time, you are looking at this the platelet antiplatelet agents and some plus or minus systemic anticoagulation.
I didn't get the role. Why do you want antiplatelets in this patient? Because it is you have a infective endocarditis. That infective thing is
It's the infective thrombus is there.
Yeah. So why do you want antiplatelets?
Just to maintain the circulations into the system, like the antiplatelets has been considered for a patient who has active infective endocarditis, but not for all patients. So that is why like we need a help from entire. Yeah. So it's not going to, I mean, I'm not going to take a decision that I'm going to anticoagulate or give antiplatelet to this patient. So it's a team decision.
Any role for prophylactic CT angiography to diagnose mycotic aneurysm?
Yeah, so it depends. Like CT angio probably will help when patient is having a longer duration of bacteremia. So when patient is having persistent positive blood cultures, these are the patients who are likely to get the mycotic aneurysms rather than the acute onset of bacteremia. You make a diagnosis and you put them on antibiotic therapy. The chances of mycotic aneurysms are very minimal. But those patients who are neglected case, received a very late diagnosis, persistent culture positive, they are at a very high risk of mycotic aneurysms.
Any other questions? Okay, then in that case, we'll move on to the next topic. Yeah, please.
So, why is rheumatic heart disease considered as an intermediate risk factor? Is it because they receive some sort of antibiotic prophylaxis, or compared to, say, congenital heart disease? In that.
So this is a very good question, but I mean, I do not have a correct answer why they have, I mean, stepped down the rheumatic heart disease, because when I was doing my post-graduation, the rheumatic heart disease are on the top of the cardiac risk factors. But now they have stepped down, probably because of the advancement in the medical science, where now we are using more and more prosthetic valves. We are using many the prosthetic material to suture or to repair the cardiac valves. Previously we were not using CRT device or the other devices which supports the heart, like the pacemakers and the CRTs and others. So because of this additional risk, I mean, they found that probably they are having a much higher risk as compared to the rheumatic heart disease. That's why probably they have stepped down, but I mean, I'm not sure. Yes. So even like right now also, like we have, I mean, sent before I come to Kottayam, we have referred one patient to CT surgeon for the surgical repair because patient has severe mitral regurgitation. He has completed 6 weeks of therapy, and the Streptococcus pyogenes was the organism sensitive, and he's fine. So we have mentioned clearly that, and I talked to the surgeon that you have to send the wall which has been resected for histopathology as well as the culture from that infected area, not from the general healthy wall. So this is very important because nowadays, like they have also included the surgical criteria or the pathological criteria as one of the diagnostic criteria, even though like the recent patient has confirmed diagnosis, all two major criteria were satisfied: blood culture positive, 4 bottles were positive, and there is a large vegetation, and now the wall is also damaged during the infectious process. So patient is having a satisfactory criteria and completed 6 weeks of therapy also, but still I would like to know whether the organisms were alive at the time of surgical therapy or not. So coming to the another very common infections and interesting infection, that is tuberculosis in ICU. So we all know the global burden of tuberculosis, and I'm not going to spend much time on this global burden. The only thing that I would like to highlight over here is that if you look at the size of the circle, it is the biggest over the India. So India is bearing a very high the TB burden globally, right? And the almost like 10.6 million people they develop tuberculosis, and the almost 1/3 of the patients are from India. So if you look at the global burden, 1/3 of the patients are coming from India, and we do have a large number of the multi-drug resistance tuberculosis. But the issue here is that tuberculosis in ICU patients, where we expect very high mortality in a tune of more than 50%. So that is the question today that we are going to understand. So what are the common tuberculosis setting which can lead to the ICU hospitalization? So those patients who has severe pulmonary tuberculosis, miliary tuberculosis with some significant respiratory distress, tuberculosis with sepsis, so blood-borne mycobacterial infections, patient with pulmonary thromboembolism with tuberculosis, massive hemoptysis, the immune reconstitution inflammatory syndrome following either anti-TB therapy, or if patient is HIV, then HIV plus anti-TB therapy, and the CNS tuberculosis. These are the general TB related conditions where the patient will be brought to the ICU. So in the definition of the severe tuberculosis, generally the immunocompromised patients, like the patient with HIV, uncontrolled diabetes, receiving steroids or transplant or some biological targeted therapy, these are the conditions where the patient's immune system is hampered a lot, and patient will have severe disseminated tuberculosis. And this is a CT scan of one of my recent healthy adult female patient, around 36 years old, and she presented to our clinic with miliary tuberculosis, and she was hypoxic at the time of presentation with running very high grade fever. So this such type of healthy patients, they also get a severe forms of tuberculosis and requiring ICU hospitalization. So probably this is because of the intense inflammatory reactions around the tuberculous focus into the lung, which leads to the alveolar capillary damage, leaking of the fluid, leading to the hypoxia, VQ mismatch. Patients can have the end arteritis because of the tuberculous infections, giving you hypoxia. So the severe tuberculosis can occur in otherwise healthy young patients. The interstitial granuloma and the obliterative endarteritis is the conditions which gives you the hypoxia. And of course, like we cannot forget the adrenal glands, right? So adrenal crisis is not uncommon in TB infected patients. But apart from this severe pulmonary tuberculosis, the drug toxicities will also bring your patients to the ICU hospitalization. And we know that like all these three drugs, very important drugs, can cause acute liver failure. And the Indian data says that almost 5 to 25% of the acute liver failure patients in India are because of the anti-TB associated therapy or the toxicity. Now let me take you to the drug toxicities. So this is one of my patient, HIV infected patients, 32 years, and he has AFB3 plus tuberculosis, started on standard 4-drug therapy. The baseline CD4 count was less than 200, 175, and the rest of the things was normal. HIV, HbSAg-VDRL was negative, and X-ray showed the only right basal infiltrates. That is a very common presentations, like lower lobe involvement is seen with HIV infected patients. But at 1 week, the patient has asymptomatic transaminitis. So SCPT, which was normal 24, increased to 96, And alkaline phosphatase was also a little bit increased to the upper level normal. 128 is upper level normal. So even though like he do not have symptoms, like I asked him to repeat the liver function test at the end of another 1 week, and there is further increase into the SGPT to 141. He was asymptomatic. The alpha increases to 172 and bilirubin was normal. So even though like patient do not have symptoms, but the SCPT or the transaminitis was approaching 5 times upper level of normal. So it was not 5 times, but I have stopped anti-TB therapy. So all hepatotoxics were removed and he remained well. Appetite has, I mean, he was all right. He does not have any symptoms, but SCPT started reducing. So 108, alkaline phosphatase also drops from 170 to 111. So because I mean, he do not have symptoms previously also, so I have re-challenged him with rifampicin at a dose of 300 milligram. And look at the sequence of event that patient had. So after 45 to 60 minutes of the consumption of rifampicin, he complains of dizziness, vomiting, chilly sensations into the body, and breathing difficulties and weakness. Right. So within an hour of consumption of 300 milligram of rifampicin, these were the symptoms. So he was brought to the ER. The systemic examination at ER was showing skin flushing, diffuse erythema around the generalized erythema. Temperature was 102.8 degree Fahrenheit. There was a tachycardia, there was a hypotension, and the saturation was 91. So in ICU, like he had a progressive breathlessness, requiring BiPAP supports, continuous high fever despite IV dexamethasone 2 cc 8 hourly along with the paracetamol and the tepid sponging. Persistent hypotension, remains hypotensive with a wide pulse pressure of 80/30 despite massive fluid replacement. Now X-ray showed the bilateral opacities, probably the acute lung injury. Look at this temperature chart. So 5 days of the ICU, his temperature remains elevated despite all 3 measures: IV dexamethasone, IV paracetamol, and tepid sponging. On day 5, the patient's temperature returns to baseline. And the serial blood count showed there is a fall in the platelet count. The SCPT on day 1, which increased to 200, reaches to 82 on day 7. The creatinine remains normal. This was his the X-ray which showing the bilateral of basal opacity. Initially, he had only right lower lobe. Look at the skin rashes, right? It is again looks like a vasculitic type skin rashes, erythematous, and these are the photographs were taken when patient has started recovering. These were the follow-up X-rays, and at the end of 3 weeks, his X-ray returns to normal. So what was this? This was a rifampicin hypersensitivity reaction, right? So just 300 milligrams of rifampicin, and the event will start within a minute, right? So once the patient has rifampicin hypersensitivity, high-grade fever, skin rashes, acute lung injury, this can happen like interstitial nephritis, acute liver failure can occur with the hypersensitive pneumonitis because of this rifampicin. So fever, skin, hematological manifestations, especially the thrombocytopenia, immune thrombocytopenia are very common with rifampicin. The patients can have the WBC series will be affected by leukopenia, agranulocytosis can be seen, and pure red cell aplasia has been reported with rifampicin hypersensitivity reactions. So patients can have acute lung injury. Probably this patient has acute lung injury and requiring oxygen support. Hepatitis has been described. The interstitial nephritis is also very common with hypersensitivity pneumonitis or the rifampicin hypersensitivity, and overall mortality is very high. Fortunately, this patient was staying very close to the hospital, so immediately he rushed to the ER and he was saved because of fluid replacement and supportive care. So your drug toxicity will bring your patients to the ICU. The another case scenario, the first time diagnosed tuberculosis. So this is a very recent patient, 56 years male from the Jodhpur. He had off and on fever since last 1 month, weakness, weight loss of 15 kg, and he was coming to the ICU because of the CNS issues. So somnolence and retention of urine had altered sensorium for last 6 days. He was working in a stone mine at Jodhpur for 30 years, and now he is working in the transport. So he has left his stone mine work, but he has a very impressive habits of of him consumption for last 20 years. He has left alcohol since last 5 years, but he continued to have tobacco chewing and the smoking, and no other significant past medical illness. So in ICU, like, because I mean this with this history, like we are looking for some CNS insult and some infective conditions. So this patient has this X-ray, ET secretion showing AFB2 plus and tuberculous meningitis and multiple tuberculomas. So patients with tuberculosis with this such a disseminated or severe form may directly come to the ICU. So what are the treatment challenges of tuberculosis in ICU? This is again very important and probably the ignored subject. We have to understand that the PKPD of the anti-TB drug in ICU admitted patients are highly deranged. The reason is that many of the patients who are unconscious and they are on the nasogastric feeding tube. So enteral absorption issue in the critically ill patient, you have crushed the tablet and you administer through the nasogastric tube. So that will also affect the pharmacokinetics of the patients. The second important issue would be the drug-drug interaction, because rifampicin and the isoniazid both are having the hepatic microsomal enzyme affection, and that can give you a drug-drug interaction. So we'll see that why these two drugs are very important. And the toxicities, like toxicities we have already studied. So these are three important treatment issues in a patient admitted into the ICU with tuberculosis. So what are the important PK challenges of anti-TB therapy in a patient with critical illness? So when you are administering the rifampicin and isoniazid together along with your enteral feeding through the nasogastric tube, it will significantly reduces the bioavailability of the administered effective anti-TB drugs, right? So this is the South African study which has demonstrated that only 30% of the critically ill patients who achieved the therapeutic levels of isoniazid and rifampicin in ICU admitted TB patients, right? So that means that large proportion of the patients are not achieving adequate isoniazid and rifampicin level in patient with tuberculosis. In addition to this, like critically ill patients, they may have the renal replacement therapy because of their renal dysfunction, and the volume of distribution would be very high. So all these factors and the ECMO and other supportive cares, all these factors further added to reduces the exposures of effective anti-TB therapy, right? So these are very important consideration of the PKPD parameters in TB infected patients in ICU. So how do we treat? So parenteral TB treatment is generally preferred, and it is very useful to bridge till the patient recovers from the critical illness. So try to infuse the intravenous drugs as much as possible, because this will avoid the patient who has gastroparesis or the intestinal paralysis. So the important drugs that you can give intravenously, though rifampicin is not available nowadays in India. When I was doing my post-graduation, the Rifadin IV was available to us. The moxifloxacin is available today for intravenous use, and amikacin is also available to us. The intravenous fluoroquinolones can improve the survival of critically ill patients with pulmonary tuberculosis, right? So even though you are giving the other drugs by nasogastric route, but if you are adding the two intravenous drugs like amikacin and moxifloxacin, that can improve the outcome of this patient. There are studies looking at the higher dose of rifampicin, that is 15 milligram per kg, along with the intravenous fluoroquinolones, either levo or the moxifloxacin, and that has been found to be associated with the improved survival in critical ill patients. And the third important thing is that because we know that 1/3 of the patient achieves the adequate therapeutic levels, so you can go for TDM of this anti-TB therapy. So when you use a parenteral therapy for the treatment of TB in ICU admitted patients, the study says that there is no difference in the sputum conversions or the culture conversions as far as the TB is concerned when you compare intravenous versus oral therapy, right? But the patient who has received intravenous therapy for at least 10 days or more, it is associated with the 2.5-fold better outcome as compared to those patients who has received shorter duration of intravenous therapy, right? So as long as you can give intravenous therapy, probably it's going to help to improve the survival benefit. And study also demonstrated that every additional day of intravenous days increases the odds of treatment success, right? So try to give intravenous therapy to your TB infected patients with critical illness, and it's definitely improve the survival. And in that study, like there is no increased risk of unfavorable treatment outcome because of intravenous dosage. The same study says that when you are using IV rifampicin, it lowers the mortality and 35% as compared to the patient who did not receive. So there is a huge difference, 51% to 35%. Right? So if intravenous rifampicin is available, probably it will further reduces the risk of death. And the reason is very simple, because when you are using a parenteral medications, you are going to achieve the target early, because you are bypassing the GI route where the absorption is limited because of various GI conditions. The levofloxacin and amikacins are the most commonly used intravenous therapy in this meta-analysis, right? And they found that even though like patients are not receiving intravenous rifampicin, but levofloxacin and amikacin is associated with the survival benefit. Now coming to the case, like how we can incorporate the TDM into our day-to-day clinical practice. So this is a young female, 17 years female, weighing just 36 kg, and she is having disseminated tuberculosis, right? She has miliary tuberculosis, tuberculous meningitis, intracranial tuberculomas, lymph node tuberculosis, and the right elbow tuberculosis. And all from 3 sites, like gene expert was positive and rifampicin resistance was not detected. And she was on anti-TB therapy, which was highly suboptimal. Like she was receiving amikacin 250 milligram thrice a week, isoniazid 150 milligram, rifampicin 300, PZA 750, and ethambutol 400 milligram, plus prednisolone. So I mean, this was a regimen that she was receiving since last 1 month, and she came to us because of the altered sensorium, despite like she was receiving this anti-TB therapy. So it's very clear that she is receiving a highly suboptimal therapy according to her weight. So this is what I told you, that I mean, she has gene expert positive from all the samples, and CT scan was also showing lesions, elbow is also showing destructive lesions. She was negative for HIV, and the rest biochemistry was normal. So there was no clinical response, and high-grade fever continued despite the 4 weeks of this suboptimal anti-TB therapy. And when she came to us, like we just adjusted the isoniazid to 300, rifampicin to 450, and PZA 1000, ethambutol 800, and amikacin 600 milligram a day, with the hope that probably she should respond to this therapy. And all the oral drugs were administered through the NG tube because she was having altered sensorium. The prednisolone was changed to the dexamethasone because she has grade 3 tuberculous meningitis. She was with altered sensorium. 4 milligram 8 hourly and with tapering every 7th day. But she did not respond. Like she continued to spike very high grade fever despite this adjustment. So we look for the therapeutic drug monitoring for this patient. So after 1 week of this drug adjustment, because she is already receiving 4 weeks therapy plus 1 week, so we check for the isonex and rifampicin peak levels. The rifampicin was not detected, and the isoniazid was less than 1. So virtually there was no drug into the circulation. So dose was adjusted to increase the isoniazid to 450 milligram and rifampicin to 600 milligram. And again, we repeated after 1 week. So another 1 week that patient has gone. Now the rifampicin level reaches to the 6. Still it is suboptimal. And the isoniazid level was 2.4. Still it is suboptimal, right? So we increase the rifampicin to 900 milligram a day and isoniazid to 600. So the rifampicin level reaches to a very good level, so 21, but isoniazid reaches to the toxic level, right? So we step down the isoniazid again back to the 450 milligram, and we continued the rifampicin in 900 milligram. And amikacin was discontinued after 19th day of TB therapy, right? And gradually she has a clinical improvement in the clinical conditions, fever has disappeared, and she remains in the hospital for almost 1 month in our care. She tolerated this very high dose of isoniazid and the rifampicin, like 900 milligram and 450 milligram, for entire duration of therapy without any toxicities, right? So this is how like you can incorporate the therapeutic drug monitoring to your TB patients into the ICUs. Now coming to the another important challenges that you are going to face in ICU while treating tuberculosis, and that is drug-drug interactions. We all know that rifampicin is a potent inducer of cytochrome P450, and probably we are not looking at the isoniazid, which is inhibitors of cytochrome P450, right? So when you are not using rifampicin, then you expect the inhibitory effect of the isoniazid on the cytochrome P450. But when you combine isoniazid plus rifampicin, then the isoniazid inhibitory effect is nullified, and the predominant effect that results into the induction. So that leads to the increased metabolism of the drug, which is being metabolized by the cytochrome P450 system, right? So all the drugs which are the substrate for CYP4P450 will be metabolized rapidly. So you will get the low exposure of that particular drugs, like the azoles antifungal therapy, your tacrolimus, sirolimus, all these drugs, cyclosporin, which are being metabolized by this cytochrome P450 system, will be less. So you need to be very careful when you are administering rifampicin along with the other drugs which are substrate for CYP4P450 system, right? So drug level monitoring of these additional co-administered drugs is very essential when you are treating tuberculosis in ICU admitted patients. Now the third issue would be use of steroids. One example we have seen that the HIV negative tuberculous meningitis patient with stage 2, stage 3 tuberculous meningitis, steroids are highly indicated and they are associated with the improved outcome, reducing the morbidity as well as the mortality. But when you are using steroids in stage 1 tuberculous meningitis, where patient is walking, patient is having just mild headache, patient do not require hospitalization, the beneficial effect of steroids has not been documented, right? So stage 2, stage 3 TBM, steroids are recommended. The patient who has tuberculous pericarditis in HIV negative patients, again, steroids are very useful to prevent the sequel of the tuberculous pericarditis, that is constrictive pericarditis, and found to be very useful. And we know that rifampicin is a potent inducer. So this patient who has a subtle the adrenal insufficiency, they are likely to get overt adrenal insufficiency because the metabolisms of the corticosteroid will be increased in presence of rifampicin. So even though like patients having a little bit lower level normal stable adrenal functions, once you put them on rifampicin based therapy, there will be overt adrenal insufficiency, right? So adrenal insufficiency because of tuberculosis and augmented adrenal insufficiency because of the additions of rifampicin is also one of the indications for use of steroids in TB infected patients. Now coming to the prognosis, the patient who has severe tuberculosis, prognosis is very poor and ICU mortality is reported very high, especially when patient is having a disseminated tuberculosis underlying immunosuppressions. And these are the patients who are likely to get additional the hospital associated complications, right? Nosocomial pneumonias, multi-organ failures, and patient who has the destroyed lung, they are likely to get the chronic pulmonary aspergillosis and other secondary bacterial infections, and they tend to die. This study is from the graph from the right side is from HIV infected patient who has the blood culture positive for Mycobacterium tuberculosis. So these are the severe patients, and you can see that the patient whose blood culture is positive, they are likely to die during the treatment. The critically ill patient with tuberculosis of any severity, but patient is having a critical illness with some the vasopressor requirement, renal support requirement, or the renal replacement therapy, their prognosis is poor as compared to the patient with critical illness of the similar degree because of the other etiologies, right? So it's very clear that like the patient, this green bar is like all ICU patient with some critical illness, and this blue bar is patients with critical illness with tuberculosis with renal replacement therapy or the additional supports. So their prognosis as compared to the other critical illness patient is much poorer. And the factors which are associated with the poor outcomes are the increasing age, the patient is on immunosuppressive therapy, the severe tuberculosis, other comorbidities, need for intubations, and the renal replacement therapy. I'm not going to touch upon the infection control in ICU, but this is again a very important topic, probably that you can learn during the stewardship program or the hospital infection control program. So take home messages from this TB in ICU. The disseminated severe form of tuberculosis, host inflammatory response, intracranial tuberculosis are the common TB conditions which requires or which brings the patients into the ICU care. The parenteral TB drugs are desired as it improves the outcome in critically ill patients. So try to give as long as parenteral is possible. The drug-drug interactions are very common, especially when you are on rifampicin. And the TDM of the anti-TB drugs, especially in a patient with severe critical illness, is very important in selected patients to optimize your the therapy. And TB associated mortality is very high in ICU admitted patients. Thank you very much for the patience listening.
Any questions? Anyone who is awake who would like to ask a question? Yeah, please.
TB should have full of questions.
Yeah.
So the parental therapy, is it add-on to your usual therapy, or
Sorry?
the parental therapy that you mentioned, IV therapy,
Parenteral therapy, yeah.
is it add-on
It is
to
add-on to the standard therapy.
add-on to standard
So
therapy?
patient is receiving HERZ plus amikacin plus levofloxacin.
Okay.
That is what that meta-analysis is describing.
That you consider only if oral absorption is
Yes, you have to
problematic.
breach the time till patient recovers and the GI integrity and everything gets settled. So like in my patients, I have stopped therapy amikacin after 19 days. Right, it was more than 10 days, but I have stopped on 19th day. So once patient is start improving, patient is taking oral therapy, and you are satisfied with your the clinical response, then probably you can stop intravenous therapy, including levofloxacin. Because when you have a drug susceptible tuberculosis, like my patient has a drug susceptible tuberculosis, even though like we do not have the TB culture because it patient was evaluated at some other place and TB culture was not sent. So drug susceptibility be like you continue focused on standard therapy rather than giving additional therapy. But to breach the time duration, you have to use parenteral therapy because that improves the outcome. Yeah, so I mean, this meta-analysis has not touched upon the MDR-TB, but I mean, obviously, like we do not have the good injectables for MDR-TB apart from the linezolid and the quinolone. If it is sensitive for your tuberculosis. But of course, like if your aminoglycoside is still sensitive in MDR or the extensively drug resistance, you can use aminoglycoside plus linezolid plus quinolones.
You are using a parenteral therapy in a patient who is having drug sensitive tuberculosis to bridge the gap.
Yeah.
Does that predispose or does it risk the
No. So generally, I mean, because like patient is receiving standard therapy and we expect the early bactericidal effect of rifampicin, right? So most of these patients, more than 90% of the organisms will be cleared within 3 to 4 weeks of rifampicin based anti-TB therapy. So chances of emergence of resistance and the XDR or the MDR is much less because patient is having drug sensitive tuberculosis. So your additional exposures of aminoglycoside or quinolones is not going to hamper.
Regarding the steroids in pericarditis, the dose and duration is defined. But what about the steroid dose and duration iris?
So iris, like I mean, there are two host factor where we expect iris. One is HIV negative patients where you can get paradoxical worsening. So in HIV negative patients, the general time frame for getting the immune reconstitution disease would be around 90 days. So once you put your patients on effective anti-TB therapy, the paradoxical worsening starts at around 90 days, not before that. In HIV patient, it will be early. As soon as you start them on anti-HIV therapy, within a week to 10 days time, you will end up with the iris. So this is one difference. The HIV negative patients, their iris is generally mild, and if you give them just supportive care, then most of the iris will subside in 10 to 45 days time. So HIV negative iris is generally lasting for 10 to 45 days, and most of these patients will get stable. Whatever increase in the size of lymph node, whatever increase new appearance of the lymph node or some systemic symptoms will subside with giving us the supportive paracetamol or some supportive care. Very few patients, HIV negative patients, especially the intracranial iris or intracranial paradoxical worsening with increase in the size of intracranial granulomas with perilesional edema where you require corticosteroid therapy. So again, you are going to give this corticosteroid therapy for intracranial lesions for a pretty long time, right? Because the perilesional edema is giving you a pressure symptoms, midline shift or some clinical or the neurological deterioration. So in this situation, we are going to use a little longer corticosteroids, but for lymphadenopathy and other paradoxical worsening for HIV negative patients, probably I try to observe them, give them supportive care, and if patients having massive increase and giving you a severe pain in the lymph node enlargement area, then I give 1 milligram per kilogram prednisolone therapy with tapering every 5 to 7 days, depending on the clinical severity. My aim is to taper as soon as possible. So most of the time, like I will try to taper at 5 days. But for patient who has massive and the paradoxical worsening, I continue it for 7 days and then slowly taper for controlling the symptoms. For HIV positive patients, like you have to continue with the your antiretroviral therapy, and you have to again use the prednisolone same dose 1 to 2 milligram per kilogram. So for patient who has life-threatening intracranial iris with altered sensorium, seizures, where you are going to use higher dose of the steroids as compared to those patients who has carinal lymph node which is enlarged, producing some cough or some pressure symptoms into the chest, or some enlargement of the peripheral lesions, or some enlargement of the pulmonary focus giving you more cough and more the chest discomfort, where 1 milligram per kilogram prednisolone is good enough.
You're asking about the duration.
Yeah, so duration, like again for HIV, like for milder symptoms where I have to compel to use prednisolone every 5 days, I used to taper and stop.
Any other questions? Thank you. Thank you, sir. Yep.
So 4-drug regimen, 4-month regimen you are asking about, right? So this has been studied in African countries in pediatric tuberculosis patient, and they have limited disease, limited nodal disease, right? So here, like they have demonstrated a good efficacy of 4 months regimen, but there are other regimens for 4 months for the treatment of drug susceptible tuberculosis, where they are using bedaquiline also, and these regimens are not been approved, but the trial has been published into the NEJM, where they have shortened the duration from 6 months to the 4 months for the treatment of drug susceptible tuberculosis. So we have two separate studies. One is for pediatric TB patients, and second is for drug susceptible TB in adult patients. But that regimen for adult patients, like they have used a standard HERZ, and the for first 2 months where the patient is receiving pyrazinamide and all these 3 other drugs, and the tail was with bedaquiline and moxifloxacin, and the second tail was clofazimine plus moxifloxacin, and I think they have also used linezolid plus bedaquiline as a. There were 5 comparators in that study.
There are no more questions. We'll move to the next session. Thank you. Thank you, sir.
Yeah.
Thank you so much, Dr. Atul. Next, I invite Dr. Aravind R to present on viral sepsis in the ICU, recognition and management. Over to you, sir.
Good evening. I think when we hear the term sepsis, what comes to our mind is always used to be like a bacterial sepsis. But now everyone is familiar with the definition of sepsis. The immune dysregulation, host immune dysregulation could be due to any trigger. It could be a bacterial trigger, viral trigger, fungal trigger, or parasitic trigger, like that. So the job given to me is how to recognize this in the ICU, how to differentiate based on the clinical features or the lab biomarkers, etc. How to differentiate between a bacterial cause of sepsis and a viral cause of sepsis. So based on the study you referred to, the viral infection could lead to sepsis in around 30% of cases. These are studies which came after the COVID era. Okay, so around 60% of sepsis in the ICU is due to bacterial causes, around 30% due to viral causes, and around 5% due to fungal etiology. But the previous studies put a figure like around 3 to 4% of the sepsis could be attributed to the viral factors. So sepsis in viral infection is basically cytokine storm triggered by the viral components, the host cells as well as the cytokines. Okay, so in that way it is very, very similar to the bacterial sepsis. It's a very, very complex disorder with the involvement of cellular and humoral components and present quite divergent biological and clinical patterns. Okay, so what basically the pathophysiology in viral sepsis is actually the antigen triggering a cytokine storm, then the cell death, as well as the activation of the coagulation cascade through thromboinflammation. So this is the global distribution of viruses. Basically all these viruses can lead to the viral sepsis sort of things, and WHO has mapped it into 6 global regions with what virus is predominant in that region, etc. Okay. The only one good thing about the global warming is that, say, the common viruses like dengue, chikungunya, etc., which can trigger viral sepsis in Southeast Asian diseases like dengue never had an active antiviral drug, and recently only we have access to effective vaccines and all. Because of global warming, what happened is that the temperature, ambient temperature in Europe, US, etc., went up, so that this Aedes mosquito can multiply very well in the Europe as well. So they are having autochthonous transmission of dengue, chikungunya, etc. in Europe as well as US, because of which now we have access to very effective vaccines against dengue as well as chikungunya. Now, coming to how to differentiate between a viral cause of sepsis and a bacterial cause of sepsis in the ICU, it may not be easy, but there are certain clues. That the viral infection is likely to be a systemic infection. Okay, multiple systems will be involved. So, just as a case study, how to differentiate between a viral cause of pharyngitis and group A beta hemolytic streptococcus induced pharyngitis. So, if there is presence of conjunctivitis, rhinitis, so diarrhea, hoarseness of voice, if there are oral ulceration, rash sort of thing, it points towards what? Probably viral etiology, because all the viral infections are systemic infection. Whereas a streptococcal pharyngitis is limited to this area, so you are not going to expect transaminitis or a oral ulceration or the mucosal lesions or conjunctivitis, etc. This just to to take you through the point that viral infections are often multi-system infections. And looking at the biochemical clue, I'll take you through this case. Is a 15-year-old boy vaccinated for age, present with fever and membranous tonsillitis of 7 days duration. And on admission, patient was dyspneic, tachycardia, transaminitis was present, and because of myocarditis was admitted into the ICU. So what is the diagnosis here? Is actually membranous tonsillitis due to? Okay, so is membranous tonsillitis due to Epstein-Barr virus? Okay, the clue here is that there is transaminitis. Usually in diphtheria, you are not expecting transaminitis. So this is how at the bedside, because this is a vaccinated boy, but in certain cases, the vaccination status, we may not be able to really check whether the boy is completely vaccinated or not, and the boy will present with membranous tonsillitis. The question here is that we have access to the diphtheria, PCR, and all those stuff, but the turnaround time will be around 48 hours, and the guideline is to immediately give the anti-diphtheria serum. Okay, so basically we will take a decision based on you just look at the lymphocyte count there. There is lymphocytosis. So the commonest cause of membranous tonsillitis in our part of the world in the vaccinated is Epstein-Barr virus infection, and the clues are going to be not only lymphocytosis but transaminitis. Okay, so usually in diphtheria it will be confined to this area, and you are not going to get any sort of transaminitis. Okay, but suppose this happens in a child who is not vaccinated, definitely we have to go by the PCR, and serum has to be administered, because there are case reports where there has been co-infection with IMN plus diphtheria. Now coming to the pathophysiology of cytokine storm in viral sepsis, you know that all these viruses, may be dengue or say Ebola or whatever it is going to be just an antigenic trigger. So what it contributes is the viral proteins will act as the pathogen associated molecular patterns, and then the damage associated molecular patterns are also there, and these are recognized by the toll-like receptors and node-like receptor, and there is going to be cytokine release and cytokine storm leading to multi-organ dysfunction. So this picture is, I think all of you are familiar with this picture that we had during the COVID time. So what actually we experience in severe SARS-CoV-2 infection is, this SARS-CoV-2 is just an antigenic trigger, and this lead to immune dysregulation, endotheliitis, and activation of the coagulation cascade. So that is how all the vessels have this thrombus inside it. So this is the domino effect, which is well described in the pathophysiology of this the genesis of severe COVID-19 infection. And the Yale University used a platform known as a REAP, that is a rapid extraction of extracellular antigen profiling, rapid extracellular antigen profiling. So using this platform, within say 1 hour, they were able to identify antibodies against 2,500 extracellular antigen, and that is how they proved that most of the post-COVID complications are due to the presence of diverse functional autoantibodies. So basically, what viruses does is that it sets in motion a cytokine storm. Then this will lead to not only COVID-19, most of the respiratory viruses which lead to viral bronchopneumonia can result in endothelial barrier disruption, dysfunctional alveolar capillary oxygen transmission, impaired oxygen diffusion capacity with activation of coagulation and inhibition of fibrinolysis. Okay, so basically, after our experience with COVID-19, when we assess what is happening with regard to the pathophysiology of leptospirosis, cryptyphus, etc., almost everything is the same. So all these infections which affect the endothelium, like today morning, Praveen was describing about pneumococcus leading to endothelitis, etc. So the insult is, the inciting agent is different. It could be leptospira, or it could be a scrub typhus, some other rickettsia or pneumococcus, or it could be SARS-CoV-2. But what it sets in motion is the same. It leads to a cytokine storm, leading to activation of the coagulation cascade, lung injury, cell death, immune paralysis, etc. And that is probably the reason why in SARS-CoV-2, all the drugs which had this mortality benefit were the steroids, there's immunomodulators, then the JAK inhibitors like baricitinib, tafasitinib, then IL-6 antagonist, and your heparin, so anticoagulants. So remdesivir, etc., had mortality benefit only in the earlier studies when the population was not vaccinated. Now coming to the lab parameters which will help in, or the biomarkers which will help in differentiating between a bacterial and a viral cause of sepsis. Usually what we used to teach, or what we used to learn as an MBBS students, were that so neutrophilia means it is a bacterial infection. Lymphocytosis means it is a viral infection sort of thing. But in COVID, lymphocytopenia was a predictor of severity because there was lymphocyte apoptosis. So neutrophilia is not actually neutrophilia which is happening in COVID. It is lymphocytopenia. So just by looking at lymphocyte count, where it is lymphocytosis there, lymphopenia is there, won't help us in differentiating between a bacterial or a viral cause. Exceptions are there, like in the previous IMN, lymphocytosis, along with transaminitis might point to a diagnosis of IMN. But it's not the rule of the thumb that neutrophilia favors bacterial and lymphocytosis favors viral infection. Likewise, in dengue, usually we teach students that leukocytosis is not seen in dengue. But in majority of the patients who end up with severe dengue, leukocytosis along with neutrophilia is there. So just based on the lymphocyte predominance or neutrophil predominance, we may not be able to differentiate between a bacterial or a viral cause of sepsis. So this is a prospective multicenter observation study just done in Austria, so which looked at a lot of factors. They had two arms, around say 60 patients with bacterial sepsis and around 35 patients with viral sepsis, and they assessed 4 biomarkers, that is interleukin 6, procalcitonin, CRP, and ferritin. And you can see that IL-6 and the procal levels were IL-6 levels were and procal levels were highly elevated in the bacterial sepsis group, and CRP and ferritin, there was not much difference between the two groups, and in slight elevation of ferritin was observed in the viral sepsis group. So these are the box plots. You can see in the initial 48 hours, the IL-6 levels and procal levels were highly elevated in the bacterial sepsis group. Okay, in viral sepsis also there was slight elevation, but the levels of elevation were very, very high in the bacterial sepsis group compared to viral sepsis group. And you can see that the IL-6 levels returned to normalcy almost within say 48 hours, or there was a huge drop in IL-6 levels in the bacterial sepsis group. Okay, compared to that, the procalcitonin took around 7 days to come down. So there was a gradual decline in the procalcitonin levels in the bacterial sepsis group, whereas the IL-6 levels, they had a huge peak initially, but within 48 hours, it almost came to the baseline levels. Whereas there was not much difference between the CRP and the ferritin levels between the viral sepsis as well as the bacterial sepsis group. Herein you should remember one thing: in pediatrics and all, they ask for CRP. If CRP is positive, they will give antibiotics. Okay, CRP cannot be used to differentiate between a bacterial or viral cause of fever. For that, using a chemiluminescence assay, they tried a combination of 3 tests. That is, they looked at CRP, then the trail. Trail is actually the TNF alpha regulating ligand. Okay, so TNF alpha regulated apoptosis inducing ligand, and then IP120 is interferon gamma regulated protein 10. So these two proteins are elevated in the viral sepsis group compared to bacterial sepsis. You can see, in the viral sepsis group, the levels of the trail as well as the IP10 were very much elevated than the bacterial group, and the CRP was less. But they were using it as a combination of these 3 tests. Okay, but the problem here was that the negative predictive value was only 51%. So 50% of half the time you are likely to be wrong when you are using even a combination of these 3 tests. So and this just for academic purpose is that I shared the name of these 3 tests, because we know that these things are not going to be available. So this just to convey the message that even with the use of biomarkers, it may not be easy to differentiate between a viral and bacterial cause of sepsis. And then there are going to be the certain clues, like, so we are into the rainy season now, and we are expecting a outbreak of dengue, because almost the dengue cases have started peaking now. So we should be expecting an outbreak of dengue, and a lot of dengue cases may end up in the ICU as well. And we know that we have a chikungunya outbreak going on in Ernakulam now, like that. So almost all the arboviral infections are likely to peak during the monsoon season, and the seasonality is also important for 2 other infections in Kerala. That is, one is the Nipah. Previously, we used to say that I think 2018 and 19 guidelines about Nipah mentioned that the Nipah season will be from December to May, because December to May is supposed to coincide with the breeding season of bats. But unfortunately, the bats don't read our guidelines or WHO guidelines. And then we later realized that the maximum number of cases we usually get in September. So our bats usually breed from the May to September. So this is using the local data to modify our own guidelines. So in May to September, in these all endemic areas, any patient who is presenting to us with encephalitis, we should be proactively ruling out Nipah virus infection, not only from a therapeutic perspective, but also from an IPC perspective. But unfortunately, that applies to all cases of ARDS as well. If we start testing for all cases of ARDS for Nipah, I don't know where it will end. Okay. And the second aspect is with regard to Casimir forest disease. So KFD also might end up in the ICU, because KFD is just like dengue in the first week with encephalitis and coagulation abnormalities in the second week. We know that the Nilambur area, Western Ghat area, every year we get clustering of cases of Casimir forest disease, usually from November to May. Once the monsoon starts, the nimbal activity will decrease, and then we are not going to get cases of KFD. So KFD season is from November to May, and the Nipah season is from May to September. Now coming to, I will be focusing more on this dengue virus as this is the leading cause of viral sepsis in our state. So all of you know that in the first week, dengue is diagnosed using what? Dengue NS1 antigens. And NS1 antigen will be positive in the first week. And the first week, another method of diagnosing dengue is using the PCR. So all these 2 tests are available to us. From the after 5 to 6 days onwards, the IgM will become positive. The importance is that dengue NS1 is an excellent test with a very good positive predictive value, but the negative predictive value is not that great, and this varies from there are 4 serotypes, then 1, 2, 3, 4. The sensitivity of this test actually is different for all these different serotypes. 1, 2, 3, and 4, the sensitivity is vary. And in secondary dengue, the sensitivity is actually slightly lesser than that in primary dengue. So you are having a patient with all the classical features of a dengue, and the patient is developing encephalitis, but your dengue NS1 is coming as negative, but all other parameters are pointing towards a dengue. You have to do the dengue PCR, okay, especially if the dengue IgG is also positive, because in secondary dengue, the sensitivity of NS1 is not that great. Not that great means it will be around 75 to 80%, but it's not 100%. Now, another important aspect is that when we look at the case fatality rate associated with dengue fever, in outbreak years, the mortality is going to be higher. So it's not that the outbreak is occurring because of a new strain or a more virulent strain. It's not due to that. The problem with dengue is that in outbreak years, our resources will be stretched to the maximum. So in dengue, the if you ask me which is the most difficult disease to manage, I will definitely say it is going to be dengue, because the fluid management, etc., means that you need to spend dedicated time with the patient. The right patient has to reach the ICU. So if the number of patients are more, the stratification of patients who should go into ICU, etc., will be compromised. So that is the problem with the treatment of dengue in this outbreak years. If you look at the Kerala data also, I think 2017 was the year where we were really tied with dengue. There the case fatality rate was also high. The WHO has stipulated a case fatality rate of 0.05. That is the target that we are supposed to achieve. And now our CFR is around 0.2. After 2021, our reporting is almost transparent. Everything, the confirmed as well as the probable dengue cases are being reported. Here also it shows that in the outbreak years, the CFR is actually high, but there is no genetic variation to the dengue viruses which are circulating here. So it shows that if you want to bring down the mortality associated with the dengue viral sepsis, we need to have very good patient stratification strategies in place. The right patient, so you need to identify patients with compensated shock at the earliest, and they should be referred to the ICU. So for that, we need to understand the immunological aspects of dengue. We know that there are two sorts of immunity at play. One is a homotypic immunity. That is, you are infected with dengue 1, you are going to get lifelong immunity against den 1, right? And there will be the cross neutralizing antibodies, which after some time the levels will come down. So basically, if you are having den 1 infection, for around 6 months to 2 years, you will be having cross protection against all other den 3, 2, 3, and 4. But after that, if you are going to get exposed to den 2, etc., you are likely to end up with secondary dengue. So that is referred to as the heterotypic. Homotypic immunity means lifelong immunity against a particular virus. Heterotypic means this cross neutralizing antibodies, after some time the levels will fall and you will become susceptible to reinfection. And this reinfection with the den 2, 3, or 4 can lead to something which is known as antibody dependent enhancement, and this is what actually leads to the complications of dengue, like capillary leak and multi-organ dysfunction. So these are the possible events in a patient who is having a primary infection with dengue. So it usually will be a mild illness. Even the first episode of dengue can result in organ dysfunction, but usually it is going to be mild. Secondary infection with a homologous strain, this is den 1 again, there is protection, no infection. Secondary infection with a heterologous strain, if the cross protection neutralizing antibodies, the levels are low, you are likely to have something known as a antibody dependent enhancement and severe illness. And in infants who has this antibody from the mother, even the first infection can result in antibody dependent enhancement. And so vaccination, how vaccination is going to protect us is actually like, along with this neutralizing antibody, the T cell response also is going to be important. Okay, so if you're having, say, HLA linked very strong T cell response, even if there is the heterologous antibodies are subneutralizing, the chance of you developing a severe infection is going to be very, very less. So basically, if you want to bring down the mortality, you should be able to identify patients with with warning signs. You should be able to identify patients who are having compensated shock. You should not wait for the patients to develop shock. So compensated shock means the pulse pressure will be 20 or more. That is, suppose the BP is 120, systolic 120, diastolic is 100. That is actually compensated shock. So you have to identify patients at compensated shock. Look for tachycardia, look for the capillary refill time is getting prolonged and cold extremities. Handpick these patients and refer them to the ICU. Okay. And another important thing is that there is a critical phase, and during the critical phase, the capillary leakage will occur. But this phase will last only for 48 hours. If you are going to give fluid after this time, what will happen? All this fluid will come back. So our aim as ID physicians, etc., is to identify patients at the earliest who should require this very close monitoring of the IVC, olive, and all those things. Rest of the things, actually, it will be better for the critical care persons to optimize the fluid management of dengue. In ward and all, if you are going on giving the fluid, etc., what will happen is that after 48 hours, all this fluid will come back and it will lead to fluid overload like scenario. And other important steps in dengue management is in severe dengue, if the patient is not improving, you need to have this acronym in mind, that is ABCSF. Look for acidosis, occult bleeding, hypocalcemia, hypoglycemia, and fluid overload. And also look for coexisting bacterial infections. The most important aspect is identifying the occult bleeding. That is, the patient is sick and you are giving fluids and the hematocrit is actually not coming up. You have to suspect occult bleed sort of scenarios. All these things are given in detail in our state guidelines. So as far as dengue is concerned, the most important thing is to identify patients with warning signs and patients who are having this capillary leakage. And those who are having this plasma leakage, they should actually be given fluid management according using the UST guided fluid management. That is going to save the lives of the people. So as far as viral sepsis is concerned, our aim in dengue is to optimize the fluid management strategy, the correct acidosis, hypoglycemia, hypocalcemia, and administer blood products when it is really required. Now, another scenario, so this patient may not end in the ICU, but still you should know this. A 26-year-old pregnant lady, 14 weeks of gestation, presenting fever, headache, maculopapular rash, arthralgia, non-purulent conjunctivitis, and lymphedema. NS1 antigen is negative, the PCR is negative, IgM ELISA done on the day 8 is positive. So what is the possible diagnosis here? This Zika virus infection, and Zika is also endemic in Kerala. So Zika is a fly virus just like dengue, so the IgM will be positive. Okay, and the clinical clue is going to be like this lymphedema. Usually in dengue, if you are getting lymphedema, it is a marker of capillary leakage and patient will be sick. Patient is not really sick and you are getting upper limb edema, etc. It is a marker of Zika virus infection. Pregnancy with rash, the state guidelines stipulate that any patient with fever and rash and pregnancy, you have to rule out Zika virus infection as well because of the possible risk of embryotoxicity. Acute febrile illness with pulmonary syndrome, you will say it is leptospirosis. When you are talking about a virus, what will it be? It's a hantavirus. Hantavirus pulmonary syndrome. Is hantavirus endemic in Kerala? As of now, we'll say no, right? So many of the clinicians do have certain suspicions, like patients having a hemorrhagic fever with renal syndrome or hemorrhagic fever with pulmonary syndrome, etc., where lepto-PCR is coming as negative. For the last 20 years, many doctors have suspected the presence of Handa here. I think around 6 months back, this publication came from Kochi. That is out of say around 216 febrile patients. There's patients with AFI. Handa IgM was positive in 16%. This is published from LISI. So probably it means that Handa is under-recognized in our state. Okay. So in patients with pulmonary hemorrhage, when the lepto-PCR is coming as negative in the first week, think about hantavirus as well. Now coming to another interesting scenario. So most of you know about the multisystem inflammatory syndrome in children and its adult counterpart during the COVID time, etc. We all know. What happens is that SARS-CoV-2 is just acting as a antigenic trigger and it will act as a super antigen to lead to a cytokine storm, and you will get itis everywhere. There's appendicitis, cholecystitis, then pneumonitis, colitis, etc., including myocarditis and encephalitis. So why I am saying this now is, do you know that a COVID has come back and now the COVID numbers are increasing in the state? Yeah, it is increasing in the state, and last week we had a case of appendicitis with myocarditis. Okay, but the problem is to prove MISA is very difficult now. It is a diagnosis of exclusion, and if the COVID PCR is coming as negative, we used to use COVID IgG, right? But now COVID IgG does not mean anything. It could be due to prior infection, etc. So any patient presenting with appendicitis and shock, if the appendix is not perforated and it is not a septicemic shock, and if there is evidence of myocarditis, please do think about the possibility of MISA as well. And here in MISA, what will be the total count like? It will be very high. So in viral sepsis, don't think that the counts will be low. So viral sepsis and bacterial sepsis cannot be differentiated just based on the total count, etc. Usually, I said that the procal level is not that high in viral sepsis. One exception is in MISA and MISC, because it is not a really viral sepsis, right? It is pure cytokine storm. This COVID is acting just as an antigenic trigger. So whenever we are having this COVID peak, every 6 months we are having a COVID outbreaks, you need to look out for patients who are coming with very much elevated inflammatory markers, very much elevated D dimer, very much elevated procal with multiple organ involvement. Okay. And I will end with this case. This case came to us around 8 years back. A 29-week pregnant lady present with fever, sore throat, ILA-like presentation, along with loose stools, 2 days after consumption of pork. And as usual, from local hospital, Cevixame was prescribed for 5 days, no improvement. On day 6, was referred to MCH, SAT. Patient had a toxic look and fever was 102. And the lab showed leukopenia with thrombocytopenia along with transaminitis. So initially, since there was a history of pork consumption, we thought it is a gram-negative sepsis, something known as a pig bell due to Clostridium perfringens type C, and was started on piperazine and tazobactam. And since the possibility of ILA was also there, oseltamivir was also added. And all the other things, cultures, everything was negative. The throat swab panel, everything was negative. Procal was 4, but there was no serial rise. The tropical fever workup was negative. ANA by F was weakly positive. DSTNA profile was negative. Okay, then by day 7, the patient started developing multiple petechial and ecchymotic patches, and the STPT rose to 1500 and STOT. This patient progressed to acute liver failure, and we could not do the liver biopsy because of this coagulopathy. By day 10, the patient developed encephalopathy or encephalitis, probably hepatic acute liver failure into hepatic encephalopathy sort of thing. Then she progressed to develop this acute kidney injury, and the ANA was 1 plus and the serum C3 was low. But C3 cannot be interpreted when there is liver failure because C3 is synthesized by the liver. Okay. So brief summary is a primary gravida with a history of DVT in the first trimester for which the patient was on anticoagulation, present with influenza-like symptoms at 29 weeks, rapidly progressed to acute liver failure, AKA and altered sensorium. Respiratory panel, hepatotropic virus workup, tropical fever workup were negative. All the cultures were sterile. The only positive thing that we got was ANA 1 plus, C3 with a past history of a DVT. The interesting thing is that this turned out to be a case of herpes simplex in pregnancy, leading to acute liver failure. Okay, so at that time we were not really aware of this condition. This happened to us around 9 years back. Patient was started on IV acyclovir and she actually recovered. The interesting aspect is that acute liver failure due to herpes simplex in pregnancy has a associated mortality of around 50 to 60%. We assume that usually the skin manifestations will be there. Skin manifestations are there only in around 50% of the cases. So much so that Stanford, this Mayo Clinic has come out with a guidelines suggesting that any pregnant lady with ALF, and if there is presence of leukopenia and thrombocytopenia, it is better to empirically start that patient on IV acyclovir because the mortality associated is very high. The problem associated with this rampant use of acyclovir is that this HSV hepatitis accounts only for around 1% of ALF in pregnancy and 2% of viral hepatitis in pregnancy due to HSV. So the problem here is that since the mortality is very high, the recommendation is that any pregnant lady, especially in third trimester with leukopenia and thrombocytopenia, presenting with ALF, think about the possibility of HSV hepatitis, ALF as well, and this will present just like a sepsis sort of syndrome. This is actually the follow-up of this patient after 6 months of discharge. Dr. Vaishak is here. She presents with some sort of an altered behavior, irritability, and all those things. And this is patient actually had HSV encephalitis as well, and now she has present with Clover-Bucy syndrome. Okay. So basically, viral sepsis is just like bacterial sepsis. It is just an inciting event. All these viruses can be inciting events, and it triggers a cytokine storm sort of thing. So identifying the pathogen based on history or examination alone is not easy. With biomarker alone is not easy. So what is really required is a combination of history, clinical examination, and the intelligent use of biomarkers. So thank you very much.
Sure, there will be a lot of questions.
Okay, thank you.
Thank you, sir, for that insightful section. Before Before we move on to the next session, I request Dr. Jacob to kindly come forward and hand over the memento to Dr. Aravind. Next, we welcome Dr. Geedu to present on diagnostic stewardship in the ICU. So, over to you, ma'am. Good evening again. So, the second topic given to me by Jacob sir is diagnostic stewardship in the ICU. So, what is diagnostic stewardship? It's a cross-disciplinary method to improve the quality of patient care while you appropriately manage resources within the healthcare system. We'll go into the details. So, this can be implemented anywhere across the testing journey, from ordering of the test to its analytical processing, testing to the reporting of the results. What is the goal? It is to improve diagnostic accuracy and optimize your patient's treatment. What are the pillars of your diagnostic program? You can describe it by using the 4 R's. The right tests are supposed to be ordered. It should be for the right patient, at the right time, and for the right clinical management. So, diagnostic stewardship, what are the clinical components which are involved? So, this should come from you clinicians. The right test should be ordered for the right indication, and the appropriate specimen should be sent to the lab. What should we be doing? What is our participation in the stewardship? We should perform the test by the right method, accurately and reliably, and we should report it with the right interpretation. We should even communicate the report to you at the right time. So, the goal of the diagnostic stewardship is not to reduce testing, it is rather to guide value based targeted interventions to provide a continuum of care. And many diagnostic stewardship practices are also a component of antimicrobial stewardship programs. So, if you do appropriate diagnostic testing, automatically you can support the goal of an appropriate antimicrobial utilization. So, how is that? So, what is the link between diagnostic stewardship and antimicrobial stewardship? You evaluate the patient for the symptoms, the diagnostic testing is performed, empiric antibiotics are prescribed, and then you change your empiric therapy into targeted therapy. So, in the stewardship, say you have a clinical bias, say a contaminated sample is collected, say you do not use the appropriate thresholds, you cannot identify between a true infection, a contamination, or colonization, you will not be able to optimize your empiric antibiotics, somehow affecting your antimicrobial stewardship. So we'll quickly move on to one case. This was a 52-year-old female. She underwent a craniotomy evacuation of EDH. She was bedridden since then. She presented with fever, vomiting, decreased responsiveness. She had a large hemorrhage. Her urine culture was sent, which showed CR Klebsiella. Then the primary team only did a rapid carba test, which showed an NDM. Then when the ID team was given a reference, a urine routine was evaluated. It only had 10 to 15 pus cells. This was a urine sample. It was clear, you can see. Could the fever be due to the hemorrhage? That was a query. So likely it was a colonized catheter due to CR Kleb. So the decision was taken to observe closely and later on reinvestigative needed. So was this a right sample and the right test for the right patient at the right time? This was the patient. She was unable to say if she had any symptoms. She had clear non-turbid urine. Only 10 to 15 pus cells. growing a CR Klebsiella. Several high-tech tests like rapid Carva was performed showing an NDM. Whether to treat or not to treat becomes difficult later on. Other reasons of fever, vomiting also need to be evaluated. So the CT showed a hemorrhage. Like for example, you isolate a C. auris in urine. It was discussed yesterday. So this information is important only for epidemiological knowledge and infection control. You are not going to treat that C. auris in the urine. So there was a modified Delphi procedure where they tried to identify the best practices for ordering the urine cultures. So what are the appropriate practices? You need to document signs and symptoms of UTI before sending urine cultures. You have to not do reflex urine cultures. You have to replace standalone urine culture orders with, say, conditional reflex cultures. Like if there is a urine routine which is indicative, the patient has symptoms, then order for a urine culture later on. Inappropriate practices, say as a standard order test, they are a baggage of tests, which are sent from the emergency once the patient comes to the casualty. On admission, blood, urine, other sputum cultures are sent, say as a pre-op without any indication. Patient has an altered mental status and you ask for urine cultures. So all these are inappropriate practices. So this is up to ordering of the urine cultures. Now what about processing the urine cultures? Appropriate practices would be, say if the urine routine is indicative, if you have collected an appropriate sample, a clean catch midstream urine. Inappropriate would be as described earlier. And what about reporting of the urine culture? So when you have higher colony counts, still they may not represent a urinary infection. That needs to be seen according to the number of the organisms that you have isolated. Then you have to nudge the clinicians not to treat mixed flora. You have to tell them not to treat asymptomatic bacteriuria. Inappropriate is when you do not have significant bacteriuria at all, then it should be entirely clinically correlated. So again, this urine culture per se will become a most common driver for an inappropriate antimicrobial use. So there's a great connection with the antimicrobial stewardship, because you will ultimately even overestimate your catheter associated UTIs just because you have collected it from a colonized catheter. So ultimately, would like to conclude the urine culture part of it by saying that unnecessary preoperative urine cultures for asymptomatic patients, for change in mental status, we should discourage sending urine cultures. And AMSP for asymptomatic bacteria would be better if they were not sent in the first place, because you send them, they grow something, then you perform further tests, and then you will wonder whether to treat or not. You do a test, you get a false positive result. Now it's hard to convince yourself as well as the patient that it is not real. So this was a study, a large statewide study where they tried to reduce unnecessary urine cultures, and they saw that it was associated with the greatest reduction in antibiotic use. Up to 1/3 cases of UTI diagnosis were actually asymptomatic bacteriuria, which did not require any treatment. Moving on to another case to discuss several other aspects of diagnostic stewardship. This was a 72-year-old male patient, a known case of diabetes, hypertension, CKD, had a travel 1 week before symptom. There was an eye redness, sticky discharge, he had a dry cough, fever without chills and breathlessness for 7 to 8 weeks. A URTI was done because there was a suspicion of viral, it was negative. An acute fever panel was sent, it was negative. Biomarkers, fungal biomarkers like galactomannan by IMI method were sent, it was negative. Aspergillus PCR was asked for. So when we talk about fungal biomarkers or say fungal tests, non-culture based fungal tests, again we should avoid routine use. Just because it is easy to do, we shouldn't be doing it every time until and unless we have a strong clinical suspicion. And at the time of collection and processing, say you're sending out these tests, a sterile procedure should be followed, because even a minimal contamination can cause false positives. While reporting also, you have to mention the various false positives, the reasons for false positives. If not, it will be treated accordingly. So a BDG to exclude mucormycosis, then other avoid routine use of these tests outside high risk populations, and we should have a reasonable turnaround time also for the same. If not, they will start the treatment and they will wait for it to come back as negative. And we should also know that your biomarkers, Aspergillus, your BDG galactomannan will be positive. In Candida, your BDG is one which is positive. In PCP, again, a BDG is positive. In mucormycosis and cryptococcus, both BDG and galactominin are negative. So, going back to our previous patient, his features were indicative of a viral illness, likely adeno. Still, Legionella mycoplasma should have been kept in mind. A LRTI biofire was done on a sputum sample because Legionella is present in the lower respiratory biofire. And Klebsiella and Pseudomonas were isolated. Klebsiella 10 raised to 5, bin copy, Pseudomonas 10 raised to 4. CTXM was a resistance marker. When the gram stain was reviewed, it was found that the sputum quality is not optimal. Detection of these nucleic acids were not interpretable, and need for specific treatment for the same was doubtful. So then a ANA blot was positive, so there was a query whether it was a mixed connective tissue disease or a scleroderma. So now with this background, what about respiratory cultures? We shouldn't order any of them without any clinical evidence of pneumonia. Do not order tests for non-severe CAP. Where there's an isolated fever, change in secretions, elevation of inflammatory markers, that shouldn't be a reflex to order a sputum test, or if the patient is intubated, go for an ET aspirate immediately. We shouldn't be doing that, and the quality should always be checked. Again, another important mention is you shouldn't order this as a test of cure, and you should restrict repeated ordering based on the time since the last test. So ultimately, what happened to this patient? A lung biopsy was done later. All this was a hyaline membrane disease, and it wasn't infective at all. So the specimen is the first test. Your diagnostic accuracy begins with the specimen quality. Even highly sophisticated molecular diagnostics that we discussed all throughout can produce misleading results if your specimen quality is poor. And respiratory samples per se, they vary quite a lot in the reliability. The pre-analytical problems including your delayed transport, prior antibiotic exposure, contamination with saliva is very common in such samples, improper storage, or sampling from the wrong anatomical site. So they may lead to false negative or even misleading molecular detections. Moving on to another case. So from a lab perspective, we received the history mentioned to us was fever with loose stools, and we received orders for gene expert C. difficile toxin testing as well as a GI biofire, both of which was negative. Later on, we got into some more history. So this patient had fever and loose stools. He received a day of antibiotics in the ICU. A second day, the C. diff testing was performed. Actually, it was Dufalac that was responsible for the loose stools in this patient. So basically, it was a wrong diagnostic stewardship. What would happen if the NAT was positive? In our patient, the NAT was negative. If the NAT was positive, we would again think that many patients can be positive. They will be colonized, and then we will again perform a toxin detection to know if it is actually C. diff. We will ultimately get confused. So the diagnostic stewardship basically was gone for a toss. Whether you will investigate or not depends on whether you will treat or not. So what do they say for C. difficile testing? We shouldn't allow ordering if on laxatives or any repeat testing within a defined period. We shouldn't collect or accept any formed stools. Inappropriate testing, as I mentioned, will again detect colonization and expose the patients to unnecessary antibiotics. So this is a very small report. This was a pus swab from a bed sore from the sacral region, and out of which CR Klebsiella was isolated. Again, all kinds of tests, rapid carba was asked for, synergy was asked for. Ultimately, this patient will be subjected to Cazavi-Astronam. So this patient had acute gastroenteritis and he had a bed sore. So is this Klebsiella really reliable? So superficial wound swabs for culture. Again, we may be missing the true pathogen, or we may over-diagnose something which is actually not there. What about blood cultures? Inappropriate testing. You do not collect appropriate sets, do not take enough volume of blood. You collect it only from one bottle from the central line that may be colonized. Again, you will be overestimating your central line associated bloodstream infections. So you should always ensure optimal volume and the number of blood cultures, and you shouldn't be over-diagnosing and treating your contaminants. So overall, what strategies and concepts to be used in diagnostic stewardship? I'll just read 3 important ones. One, just because the tests are easy to order, you shouldn't be ordering them. They should be actually needed for your patient. A sputum is easy to collect, a urine sample is easy to send. That shouldn't be the reason for which the cultures have been sent. And what about stopping? Not allowed testing like C. difficile test if the patient is on laxatives, we have discussed earlier, and as a reflex test. Just because you want to send tests together, sending a urine routine along with a culture without even waiting for the results of the urine routine. So I would like to conclude by saying that we have to dump pan cultures, this habit of sending pan cultures. We have to change the underlying culture of culturing. We have to actually look whether it is indicated or not. Just because it's easy to do a certain test, we shouldn't be exploiting them. It has become an alternate knee jerk reflex now, a conditioned response where we want to confirm a suspicion just to rule out something. And you do not want to follow up further. That's why you want to just send a battery of tests all at once. That's a very wrong practice. So sometimes the physicians, just to be safe, even if the clinical probability is very low, they end up sending quite a lot of tests, which is again a very wrong practice. Thank you. Inviting you all once again to our fifth JIDCC, which will be from 14th of June to 20th of June. It will be a full day program for 7 days at Jupiter Hospital, Pune. So this was continued after Sir came back from Hinduja, where the IDCC certificate course. You all must have heard of all of that. So this is a kind of a mimic, I would say. We are similarly calling all the faculty from Hinduja and from other hospitals in Mumbai, as well as the ID physicians of Pune and microbiologists of Pune are coming over. Uh, some of the previous GIDCC delegates are also sitting in the hall, so you all can collect your feedback from them also, and it will be nice if we have you over there. Thank you so much. Any comments? Any queries?
I mean, all these concepts are very, very good. But my simple question, which is in my mind, I am now vocalizing it, that whether the test was needed or not, sometimes can be adjudicated only later on, not before. So, see, for example, the case which he had discussed. So that patient had lots of things which are, he had some conjunctivitis, a community acquired pneumonia. He had traveled several places in a air conditioned car. So various, our differential diagnosis was wide, including Legionella, adenovirus, and so on. So at that time, if you ask for a LRTI, means a pneumonia plus panel, I don't think it is really wrong, because you want to capture all these things. There is just no way to, otherwise, yes, empirically now many people will be on a beta lactam plus macrolide perhaps and then you might argue adenovirus probably does not require, at least in a immunocompetent person, doesn't require anything like cidofovir or any such thing. But otherwise, if you wish to know the diagnosis, that is the only way to go forward. Then when that specimen comes, then it was found to be of poor quality. So now everything has gone down the drain, right? Then similarly, now this patient was under somebody else, and then they also asked for galactomannan, PCR, uh, whatever. There was some ground glassing, so PCP. So PCP in such a person would not happen. So we have to really pay a lot of attention. But despite that, sometimes we may be forced to do a test thinking because of our diagnostic uncertainty. So it was possibly wrong because here the patient had no host factors for PCP. So trying to go for a PCP diagnosis and trying to do beta-D glucan as well as doing PCP, PCR and all these things would not be really correct. So some things are very obvious that they should not have been done, but some things are not very obvious. And after all, there is some negative predictive value of all these tests also. So that prompted further deep investigations whether this was actually a mixed connective tissue disease which was producing this lung infiltrate. And that indeed came to be true. So how will you home onto that mixed connective tissue disease without having gone through all this process? So, at times it's very easy. Some of the examples which Gitu gave are very clear cut. It is absolutely wrong to do some of these tests, like some of these urine cultures and so many other things. But in practice, uh, sometimes it is very difficult. That's what I think from, I would like to know what all of you think. about it, because you can only know later on. See, ideally one should do like this. You'll first look at the sputum. If the sputum is of poor quality, don't process it for PCR. Hmm. But is that done in most of the labs? So that is also a difficulty. Uh, so actually it is not very easy to implement diagnostic stewardship. There are clear-cut examples where something should not be done, but there are many such examples where the physician does not know whether that's the right approach or not the right approach. Any comments?
Case of the diagnosis is not that the performance of the test is mattering. Pre-analytical, analytical, and post-analytical of each of the diagnostic tests is very important. I think that's a big training required mainly for the clinician. In case of the pre-analytical and these aspects, what is the way you should collect the sample? If it is you are not suspecting at all, you are doing this test just for the sake of having bundle which have been asked for it, that is also not proper. So pre-analytical, all these points are there. What you have mentioned, I was just thinking the same points are being mentioned in pre-analytical analysis, that any test, when you should call for it, what sample should be collected, how to be collected, and what is the way of transport. Everything comes in the pre-analytical angle. And lab should first see what sample had come, and if the sample is not proper, lab should immediately report back that instead of doing this you should. But sometimes, like suppose you have collected biopsy sample, and the biopsy sample you have sent not properly, but then biopsy sample you cannot repeat again, so there you have to process it. So these are the certain scenario you have to go with this interpretation.
Okay, so this pre-analytical likelihood of something being there or not there is one of the most important and also most difficult things to do. So one should have a differential diagnosis even before one sends a test. So there has to be at least 3-4 things in your mind in that order, and then you ask for the test. Sometimes one more issue which Arunalok was talking about is the biopsy. So you have a biopsy, especially when you have a tiny specimen. So how will you prioritize which test to do on that biopsy? So that is also something which is very, very difficult, because you have a very small bit, maybe a brain biopsy, maybe something which you can't do again and again, and you can't expect a bigger, larger specimen. So in that situation, unless you have a differential diagnosis, clinical differential diagnosis, I think it is meaningless to take the next step and just try to order pan fungal something, pan this PCR and various other tests without any DD. And unless you have that DD, then you cannot say how to, you get 2-3 organisms there, which one is fitting into your scheme of things, you don't even know. So these are things which are very important. So it is extremely important to both lab as well as to the clinician to proceed in this particular manner. I think we cut corners at all stages, and that is something which leads us nowhere.
Just give one example. Like suppose in case of the fungal keratitis, usually, or any infective keratitis, usually you say that swab sample is useless. So you have to send a scraping of the ulcer which have been there. Now in a hospital like LV Prasad or Shankar Netraray, where it is eye specific directive care is there, they can do the bedside inoculation and do all the things even in inoculation in the OPD. But a center like PGI, center like Jupiter, or any of these places, it's impossible that you have to collect a sample, you send your technician to that particular area and this. So we innovated something. What we thought is that how to collect and how to send. So we found that if we collect this scraping between two slides, which is being sterile before, wrapped means it's wrapped in a crepe paper, and send it there. So the clinician collect the sample between these two slides and then wrap it and send to the lab. Lab, what they do is that one of the slide directly puts on the culture, another slide they process for this. So these are the way you have to think about also. that how to go and overcome this crisis. Otherwise, there is the problem which will happen like this. So these are the certain example where you can overcome the crisis point. So that guidance process for culture, near everything. Two slides are there. So the two slides are there. The sample is in between the two slides. So some of the sample is in one slide, some of the sample in other slide. So this one slide you put it on culture directly in the lab coming there. Don't disturb at all because it's a sterile site. Put on a plate, and this plate can be. Yeah. So it's a petri dish. The petri dish can be blood agar where bacteria can go, fungus can also grow. So you put it on there. Other slide, you put it calcofluor or any stain which can directly see both bacteria and fungus, so that at least you can use that same way for identification. So this is the technique which we developed.
Any other questions? We'll move to the next session.
Thank you, ma'am, for your presentation. We now invite Dr. Aravind R. to speak on epidemics and emerging pathogens, ICU preparedness. Sir, please.
Good evening once again. So, as far as emerging pathogens are concerned, ICU preparedness is very important, as we have discussed previously, because the IPC, the infection prevention and control aspect to be adopted in ICUs are paramount, especially when we are suspecting emerging infection. But unfortunately, what happens is that some PCR will turn out to be positive, and then only we will. So we will think about all these transmission-based precautions and all. Can you identify these people? Okay. So still, everyone knows. The other person is the one who identified SARS for the first time. This is WHO doctor. He succumbed to the disease. Okay. This is a problem. So the healthcare workers, who are at the forefront of emerging pathogens, usually succumb to the disease. And that is the importance of the standard precautions. Irrespective of knowing the diagnosis, we should be adopting certain practices. During the current Ebola outbreak, also one of the reasons why WHO has declared it as a public health emergency of international concern is that 4 healthcare workers also contracted the disease and died. And 2 US doctors have been flown to Germany and Czechoslovakia for treatment. Now, I think this is from January 2026. A 28-year-old gentleman hailing from Bangalore has presented with fever, headache, myalgia, fatigability, diarrhea, and rash of 2 days duration. He has arrived at Kochi airport from Nigeria 1 day back, employed as a staff nurse at Nigeria. So what should the emergency doctor do first? This can happen to any hospital anywhere in the world at any point of time, right? Okay. Today I had a call, that is one person admitted in a corporate hospital in Kochi has arrived yesterday in Kochi airport from Morocco, and presenting complaint is hemoptysis. Okay. But unfortunately, DSO wrote it down as hematemesis and melena, and now he is considered as a suspect of Ebola. Okay, even though he has come back from Morocco. So this can happen at any time in any hospital. Okay. So what should the emergency doctor do? Activate the red channel, isolate the patient, inform the HIC team, inform the district surveillance officer, or adjust the mask from chin to nose. Okay. Ideally, all these things would be done. So you should have a very good triage in your hospital. So now the Ebola, the guidelines are out. So any person who is coming back from DR Congo, Uganda, or South Sudan with travel history within the last 21 days, so you should be triaging that patient from the ER itself. Okay, you should not allow that person to mix with other people, and including your security should be using the right personal protective equipment. The problem here is that any infection anywhere in the world can reach any part of the world within, say, 24 hours. Kerala is a small state, but we have 4 international airports and 2 seaports. Okay, so any disease anywhere can reach Kerala within 24 hours. So this question, what is the answer? So what is the suspect infection? January 2026, it was Lassa fever. So had a Lassa fever outbreak was going on in Nigeria at that point of time. Now, okay, I thought that I will be speaking at 3 p.m. So I put the question like this. So call from ER Caritas 3 p.m. on today. A 28-year-old gentleman is sailing from Kottayam as present with fever, headache, myalgia, fatiguability, diarrhea, vomiting, and rash of 2 days duration. He has arrived at Hyderabad airport from Ethiopia 4 days back. Ethiopia is directly connected to Hyderabad airport. Okay, the direct flights are there. So, what should the emergency doctor do first? So you should understand the geography. Ethiopia borders Uganda. Okay, some people actually in order to come back and in order to escape all this airport screening and all may go to Ethiopia and may directly take the flight to Hyderabad and may travel to us. So ideally, it should be considered as a suspect of Ebola virus disease. No, since the maximum incubation period is 2 to 21 days. Okay, maximum incubation period is 21 days. Here also you should do all these things, and the most important thing will be the last one. That is a checklist based triage should be there from ER. So that is the Kerala state has given the guidelines that there has to be a checklist based triage from the emergency room itself. So from the ER itself, from your security person itself should be trained enough to identify people who are coming back like this. Okay. Now the incubation period matters. As of now, how many persons from Uganda, DR Congo, or South Sudan are undergoing treatment in Kerala? Take a pick. 0, less than 10, 20, 50. Less than 10. Okay. Yesterday we got an alert from central government, Union government, saying that 61 persons from these countries are admitted in various tertiary care centers in Kerala. They came for medical treatment. It's part of medical tourism. So the risk is actually not very less. Okay. Now coming to the transmission dynamics. In case of a probable or confirmed case of Ebola virus disease, who is at maximum risk of getting infected? Co-passenger in nearby seat in the flight, driver of the airport taxi, the ER security staff, ER healthcare worker, or healthcare workers in the ICU. ER and ICU. The thing is that what is common to this Ebola and Nipah is that you are not going to have a pre-symptomatic period of infection is not there. You are going to transmit the disease when you are maximally symptomatic. That is, Ebola, there are 3 phases. Initially, the first 3 days, it will be like fever, myalgia, headache. And from 4 to 10 days, you are going to have this explosive diarrhea, vomiting, etc. 10 to 12 days, you are going to have this consumption coagulopathy, modes, and the patient will die. So when they are maximally symptomatic, they are going to transmit the disease to others. That happens with Nipah as well. Suppose Nipah had a pre-symptomatic transmission, I don't think today's CME will be there. Okay, all of the Kerala would have been gone. Okay, so Nipah also transmit only from day 5 onwards during the maximum period of symptom severity. So usually these patients will be in the ICU or in the hospital at the peak of their symptoms, and that is why during Ebola outbreak, Nipah outbreak, etc., the healthcare workers are likely to get infected. Okay, while in the community they are not in the period of maximum transmissibility. And another thing is that we know that Nipah is not an airborne infection. Maximal, it could be a droplet infection. And Ebola is not a droplet infection also. There is only chance of a contact-based spread. Okay. But the issue is the things that you do in the ICU or in the ER. You'll try to make a droplet infection into an airborne infection by doing aerosol generating procedures like endotracheal intubation, bronchoscopy, NIV, etc. So whenever you are doing all these stuff, please use an N95 mask. Usually what we suggest is use a triple layer mask when you are dealing with a droplet infection. But when you are doing procedures like this which convert a droplet infection into an airborne infection, always try to use a N95 mask. The problem is that you don't know what the patient is having, right? So whenever you are doing an aerosol generating procedure in the ICU, if possible, try to keep this in mind. Okay. Now coming to outbreak response, this can happen in the ICU as well. There are 2 aspects. It could be a reactive response or a preemptive response. Reactive means, somehow you diagnose the disease and then you are firefighting. That is a reactive response. Preemptive means, you have a checklist based triage in the ER. A person is coming, so you are ordering the red channel, taking the patient to a negative pressure room, etc. That is actually a preemptive response. So all our hospitals should be somewhat, you should have a pandemic action plan sort of thing, so that you can mount preemptive responses. So this is about the important thing. So if our response is actually a reactive response, like what happened in Nipah in 2018, where there was a hospital-based spread, a lot of patients in the ICU got infected from the index patient, etc. So the diagnosis there was a bit late. That means that the spread will occur and the opportunity for control is going to be less. Whereas if you are able to diagnose these infections at the earliest, the control opportunity is going to be huge. So that is actually what happened with the Mbox case, which came to Kerala in 2021. So it was a preemptive response. The COVID also. The first case of COVID in India was diagnosed in Thrissur. Because we knew that our students are there in Wuhan, they came back, so they were in quarantine, they developed the symptoms, and we were able to identify. So that's an example of a preemptive response. Now, why standard precautions really matter and why we really never learn, despite a lot of experiences. We always falter when we are really face to face with an emerging infection. A 16-year-old girl, fever, headache, cough for 4 days duration, palpitation, hypotension, was diagnosed as myocarditis with ARDS, admitted in. So it's a corporate hospital. So got admitted in a cardiology ICU. Okay, developed multi-organ dysfunction, was intubated, mechanically ventilated, and since this was a 16-year-old girl and they were not able to diagnose what it was, and she died following modes, they suspected poisoning, and medical legal autopsy was performed at a Kozhikode Medical College. So what was the diagnosis in this case? I think the doctors from Calicut will be knowing this. Turned out to be a case of Nipah. Okay. So Nipah got admitted into a cardiology ICU. Nipah can present in multiple ways. Okay. But no transmission occurred to others because basically the patient never had a pneumonia sort of presentation. So encephalitis sort of presentation, myocarditis, etc., the chance of transmission occurring in Nipah is less. So it is said that, out of say 100 patients, 7 Nipah patients are responsible for transmission to others. These are the super spreaders, and the features of these 7 people will be the development of the respiratory symptoms with ARDS. Okay, so this turned out to be a case of SARS-CoV-2 infection. So the problem is that this sort of Nipah turned out to be a case of Nipah virus infection. Problem is that these sort of infections can get admitted in any ICU. It need not be your medicine ICU. It can get admitted in cardiology ICU, the neurology ICU, or for that matter in your multiple disciplinary ICU, etc. So all the ICU intensivists should be alerted regarding the possibility of these atypical manifestations of emerging infections like Nipah. The issue here is that the state guidelines clearly stipulate that if you are having an undiagnosed case of encephalitis, definitely you should rule out 2 infections. One is Nipah and second is amoebic meningoencephalitis. Okay. So that is there as a part of state guidelines, and if a patient dies with a diagnosis of encephalitis, and if these 2 tests are not done, questions are likely to come. But what about patients presenting with ARDS or pneumonia? That's the problem. That is a real challenge with regard to the Nipah. So it is like, searching for a needle in a haystack, and that is a problem. In Bangladesh also, like what we have in Kerala, every year there will be sporadic outbreaks of Nipah. So it's said that if you test 1,000 patients, even one may not turn out to be Nipah virus encephalitis. But the problem is, since that IPC aspect is also there, in case of encephalitis in endemic areas like Kerala, it will be prudent to test for Nipah as well. ICMR has included that in the tier of molecular testing for encephalitis in Kerala. And now coming to the emerging infections, there are a lot of emerging infections. So WHO has till 2024 used to come out with a list like this, say priority diseases for which you don't have effective drugs or vaccines. So of which the initial 4 happens to be the hemorrhagic fevers, that is CCHF, Ebola, Marburg, and Lassa. CCHF is there in Gujarat area, Rajasthan, etc. And around 30 to 40% of nurses working in Gujarat are from Kerala. So don't worry, at any point of time we may also get the disease. Then MERS, SARS, these are the respiratory viruses. Then Nipah valley fever and disease X. Disease X, as we all know, it is probably a zoonotic pathogen. At any moment of time, it may get spill over to the humans as well. So from 2024, they are not giving a blue list like this. Instead, they have grouped into families of viruses, which require more research. Okay. Interestingly, of this Nipah, Zika, Mpox was added later, and CCHF has been reported from Kerala. I think one case of imported CCHF were treated in one hospital in Thrissur around 3 years back. So out of 10 diseases, Kerala may be the only area where 4 got diagnosed. Okay. And the onus here is that, as far as emerging infections are concerned, after this 2018 Nipah outbreak, state government came out with a framework to identify emerging and re-emerging infection at the earliest, so as to institute optimal IPC measures without delay, because the death of Sister Lini was like the government wanted to avoid such instances occurring in the future. For that, we need to have effective triaging facilities in the ER rooms to optimize IPC measures with regard to standard and transmission-based precautions. And we need to create a framework for rapid diagnosis through multiplex PCR platforms, and create a framework to select deaths due to unidentified infections for pathological autopsy for diagnostic purpose. And as Sir said, so the pretest probability is going to be the clue. We cannot go on autopsying everyone. We cannot go on testing all the cases of ARDS or encephalitis or Nipah, things like that. The clues here will be like, no, you are having a clustering of cases in the family or locality. Definitely you need to find the diagnosis. If there is a travel to forest area or outside state, many say that travel to Kerala is a risk factor for all these emerging infections, because the majority of them are diagnosed here. Then history of zoonotic contact is a risk factor, and fever death without a diagnosis in immunocompetent host. So the algorithm is like that. Okay, like previously I said that majority of the emerging pathogens might present as a hemorrhagic fever or pneumonia with ARDS or meningoencephalitis, severe gastroenteritis, Ebola-like presentation. Acute liver failure we include because of the possibility of yellow fever getting imported to India. Okay, so for all these infections, we will try to rule out the common things first. Tropical fever workup and syndromic workup will be done. And if it is undiagnosed after all these investigations, probably we'll take it up for further molecular testing and sending the samples to NIV. And this is how the things work. In 2018, we had a lady returning from Qatar, and she had features suggestive of ILI SARI. No history of consumption of camel milk or meat, something like that. Clinical features and biochemical features and X-ray features were suggestive of viral bronchopneumonia or atypical pneumonia. So these were the differential phenotypes. The commonest ones are influenza A, B, Mycoplasma, Legionella, Coxiella. The issue here is, since the patient is coming from Qatar, we have to rule out MERS coronavirus as well. So one easy thing here is, if you are looking at the PROMET site, you can know whether there is an outbreak of this thing. Suppose they are transparent. Unlike India, if Qatar is transparent with regard to the outbreaks, if you are looking at the PROMET site, then you will be knowing that in this province this outbreak is going on now, like that. Okay, so we need to rule out MERS-CoV. So you need to, so this is an alert. The patient has to be isolated and tested for MERS-CoV. So basically, this outbreak monitoring unit has two arms. One is the diagnostic arm, and second is the IPC arm. Both arms are equally important. And then the first alert has to be, the clinician has to identify that this patient is coming from this area and there is a chance of MERS, etc. And the isolation has to happen. That is the OMU alert. And the immediate thing that we have to do is isolation and IPC measures. And the multiplex PCR platform has to be adopted, and then later the alert will be withdrawn. This actually turned out to be a case of influenza A. Okay, but suppose it turns out to be MERS, then it is going to be a huge mess. We want to avoid that. There's another case, 21-year-old. This person also returned from Middle East. Middle East we consider as an extension of Kerala. So a 21-year-old with fever, hemorrhagic rash, ARDS, myocarditis, AK, hepatitis, DIC, and probable encephalitis. He was working in Muscat in a car showroom and returned to Kerala following a symptom onset. Actually, when the patient came to us, it was in a day 7 of symptoms or something like that. It was on azoic level. Someone had diagnosed him as varicella zoster, but we could not see any vesicles. What we saw was this hemorrhagic rash, and you can see the blood coming through the Rice tube. He was in DIC. We could not see any vesicles. So it could be varicella, but other possibilities also we need to consider, right? So it could be hemorrhagic varicella, expanded dengue. It could be CCHF, because CCHF is endemic in Middle East. It could be any hemorrhagic fevers like Ebola, Marburg, rickettsiosis, meningococcemia, Lassa fever, etc. So since we don't know the diagnosis, what we need to do is we should isolate the patient. So we took the patient to the isolation ICU, was intubated, ventilated there, and unfortunately he expired because of multi-organ dysfunction. And the PCR from the skin swab as well as nasopharyngeal turned out to be varicella. Turned out to be varicella, and it was like, you Now ID doctors are diagnosing varicella through PCR, but in situations like this, probably you may have to use PCR to rule out other infections. Okay, because suppose it turned out to be say CCHF, the mortality is 30%, and healthcare workers are usually affected by CCHF. So if you want to avoid these sort of things happening in the ICU, need to be very, very proactive. Don't think, don't pray for PCR to turn out to be CCHF. Pray for PCR to be positive for varicella. So this is a girl from the forest. It's a 9-year-old girl. Palod is in the outskirts of Trivandrum. It is a forested area. Presented with fever of 1 week duration, followed by recurrent episodes of seizures. At presentation, child had leukopenia, thrombocytopenia, transaminitis, ARDS, myocarditis, encephalitis. The clinical diagnosis was expanded dengue, but all the dengue-related workup were negative. The interesting aspect was, since she is living in a forested area, had contact with monkeys, wild hogs, and history of poultry death in the last 3 weeks back. So basically, the initial diagnosis kept was expanded dengue or other viral encephalitic syndromes, crab typhus, and KFD was also kept, because initially it was like dengue. Towards the end of the second week, the patient developed encephalitis. The oddity here was the KFD has been diagnosed only from the northern part of Kerala. It has not been diagnosed till date from the southern part of Kerala. But we had monkey deaths in Palod area around 5 years back due to KFD. So in this situation, you should be thinking about KFD as well. But as far as IPC is concerned, KFD, there is no human-to-human spread in the ICU. Okay. Now coming to the best example of the preemptive response. That is how the first case of Mpox was diagnosed in our institute in 2022. Why I said it's the height of preemptive response is that the patient came to the hospital and said that I am having Mpox. Okay. So that is the height of the preemptive response. The moment Mpox got diagnosed in UAE and came in newspapers, etc., then we are prepared. So if an infection is reported from Middle East, definitely it will reach Kerala in no time. So we realize that these patients are likely to go to the dermatologist. Okay, because of skin lesions, the dermatologist, we train them, and since all these things came in newspaper, the people of Kerala were also aware of Mpox, that they should go to dermatologist, etc. So the patient took a flight to Kerala, and in a taxi went to a dermatologist and said that I am having Mpox. Okay, so that is the height of the preemptive response. This is the first case of Mpox diagnosed in Kerala. But at that time itself, another thing happened. A 19-year-old boy working in Dubai returned to Kerala with history of fever of 5-day duration with inguinal abscess. He developed headache and seizures on day 9 and expired by day 12. So microbiological and molecular CSF panels were negative. So what is the possible diagnosis? Okay, so basically he had an acute febrile illness and a inguinal abscess, and then developed encephalitis and died. So all the workup were done. He was admitted in a corporate hospital in Thrissur. He died. Okay, and the diagnosis was actually Mpox encephalitis. So this ended up as a medico-legal case, because the accusation was that the treating doctor missed the diagnosis. Okay, the issue was the patient was in the ICU for around 5 days, and then his parents came back from Gulf, and they got this history from Dubai, from the doctor there, that he had been diagnosed as Mpox there, and he was not informed about the diagnosis. But actually the doctors were put on the dock, because as far as the state guidelines are concerned, anyone who is coming back from the Middle East 21 days with skin lesion, they should have suspected Mpox. So this ended up as a medical legal case. And how the critical intensivists escaped from this case is that they quoted the national guidelines and state guidelines, saying that the case definition given is fever with rash, and inguinal abscess should not be considered as a rash. And that is how the doctor got exonerated. At that time, the WHO guidelines had clearly specified fever, rash, or lesions. So if we had followed the WHO guidelines, that doctor would have been in trouble. Since the national guidelines, even after this, they have not changed. But the Kerala state guidelines are now like the WHO guidelines. Any patient with fever, rash, or mucosal lesion, rectal lesion, or ulcers, or whatever it is, coming back from the Middle East, you have to rule out Mpox. Okay. So this was also published. It's actually out of the 40 cases reported from India, only one patient has died, and he had only one lesion. So probably whether it is an Mpox encephalitis or a Morg encephalitis triggered by mpox, we really don't know. PCR was positive. It was a late diagnosis. Specifically sent for mpox. Orthopox PCR, if it is positive, then they will do the mpox PCR. Okay, so here it is. When you hear hoof bees, think of donkeys in India. Okay. So basically, this was a 23-year-old gentleman from Assam was working there, and he presented with the classical features of leptospirosis. That is, by day 4, he had all the organ dysfunction, etc. So basically, fever, myalgia, ARDS, myocarditis within 4 days of symptom onset. But the interesting thing was that he was having this necrotic multiple scar-like lesions over the face, which we usually don't see in leptospirosis. Since he is from Assam and since the travel history, etc., is not known, we consider other possibilities like viral hemorrhagic fevers, rickettsiosis other than scrub, because in scrub usually you are going to have only one scar. Here multiple scar-like lesions were there. Meningococcemia is possible. Anthrax, is it possible? It is definitely possible. Okay. Then Wheel syndrome, the problem was everything else was fitting in with Wheel syndrome, but this necrotic lesions we have never seen. Actually, the patient was reported as a case of mpox, and mpox won't present like this. Okay. And then the patient died within 12 hours of admission, and we did an autopsy, and the PCR turned out to be positive for leptospirosis. Okay. So in endemic areas, all these infections can present in myriad ways. But the important thing is that it could have been anything else also. So the IPC part, that right from the casualty, this patient was isolated using the red channel, was taken into the ICU. It was a negative pressure ICU. All the PP were used. It's not like if it had turned out to be anthrax, etc. It would have been a. So this is how in all these cases should be approached. Okay, the onus has to be on IPC. And as far as Kottayam is concerned, at any time a human case of avian influenza could get reported. So that is where this epidemic intelligence, should be adopted. Like there are migratory pathways. The birds, there are Central Asian pathway as well as the Eurasian pathway, and we are actually keeping track of these pathways. Siberia is reporting H5N1 means after 1 month, Kutanad will also be reporting H5N1, and we should be prepared. Okay. Then I will end with this case. I presented in multiple CMEs. So this happened in a hospital in Malappuram. Okay, last year. The patient presented with is a lady, fever, myalgia, headache of 6 days duration, and then developed cough and excessive fatigability, and then developed alteration of sensorium, and so there was worsening of GCS. No signs of meningeal irritation. The MRI showed some discrete lesions. The EEG showed diffuse lowing. Patient had received ceftriaxone, doxy, and oseltamivir from another hospital prior to referral. And basically, the patient is having acute febrile illness, and you can see a consolidation patch. So it's a pulmonary syndrome with encephalitis or encephalopathy. Okay, and you can see the counts, and the CSF biofare panel detected pneumococcus. So pneumococcal can lead to pneumonia as well as meningitis, right? So no confusion. Patient is in the ICU, and you can see the total counts: CSF 76 cells, 60% this thing. There is no hypoglycemia, etc. All other cultures were sterile. By day, patient was not improving on appropriate antibiotics. By day 10, the patient started developing myoclonic jerks and vasomotor dysautonomia. Okay, and their definitive test was performed. This was actually Nipah. The problem here is that who will think about Nipah? Sure, sir. So the problem here is, you had a diagnosis, right? You had a diagnosis of pneumococcal. Let's say biofire was positive. Yes, sir. It's not fitting. It's not fitting. The picture is not suggestive of the CSF picture is not suggestive of a pyogenic meningitis. That is the take-home message here. Okay. And that critical care person, Dr. Jidesh, was so astute that when the patient developed myoclonic jerks, he thought of another possibility. And Nipah was done, and Nipah turned out to be positive. So as Sir said that when the pre-analytical possibility comes here, you are not suspecting bacterial meningitis. So the biofare grew pneumococcus, but still you have to critically analyze the CSF parameters as well. And one thing that you need to keep in mind is that film array has the maximum false positivity for detection of uh, Streptococcus pneumonia. So 11% false positivity is here. So imagine the IPC concerns here. Okay, the moment you diagnose pneumococcus, your mask will come down like that. So the take-home message from this case is that ICU doctors in the ER everywhere should always be on the guard. The pre-analytical possibility is very, very important. That is why I put the title as little things do matter. Here actually the clinical judgment matters. So all the doctors in that area knows that myoclonic jerks with encephalitis, we need to rule out Nipah. It is not specific for Nipah, but we need to rule out Nipah virus infection as well. So thank you very much for the opportunity. Okay. Okay.
Thank you, sir. Up next, we have a session on antifungal stewardship by Dr. Arnalok Chakraborty. Sir, please.
Okay, good afternoon to all. I think it's very difficult to draw attention at the end of the day. And when you have seen the same face multiple times, you already started disliking. And second important thing is such a wonderful lecture which Arvind has given. And after that, again coming to the fungal area would be a big challenge. But let me tell you, I will try to finish it as quick as possible, highlighting certain important points, specifically in case of the resource limiting environment, what to do and what not to do. So the agenda of myself today is that why antifungal stewardship in case of ICU? Where we misuse antifungal, can you reduce the misuse? Do we need distinct antifungal stewardship or it should be part of antimicrobial stewardship? Fourth point is if we have antifungal stewardship, what are the core elements? Specific challenges in resource limiting environment and how can we implement core element in the resource limiting environment and some innovative ideas. Okay, this slide I have shown you earlier also that empiric therapy, given it has been shown that 30 to 50% prescription in the best of the hospitals are inappropriate. Even in PGI, we tried to look into inappropriate antifungal prescription, found to be 1/4 of them. So this is a big challenge because of the cost, because of the toxicity, because of developing resistance of antifungal which have mattered. And as I have told you, we did a systematic analysis and we found that if we do diagnostic stewardship, antifungal consumption goes down, cost goes down, most important thing, mortality goes down and hospital stay goes down. And there is a study which have been conducted in US in 13 centers who are doing antifungal stewardship. They showed that there is no negative impact. Means if you are doing stewardship, your patients are not dying more in number. So when clinicians been asked why you do inappropriate antifungal therapy, their answer is international guideline is there. Have you got a local guideline? Because you say local epidemiology is different, then those is not very clear cut because PK is a big problem in case of fungi which is there. Then duration, how long antifungal should be given? Really, we don't know very clearly about it. So that's a big problem. When we do the de-escalation, that is also not clear recommendation. And clinical outcome is not depending on the just resistance to that bug. There is a issue which I said of the clinical resistance is also very important. Clinical resistance means patient outcome depends not only on the antifungal resistance but also patient's other clinical conditions. And of course, high cost, low affordability, these are all being important. So you may say that you have to give this therapy, but ultimately I could not avail it because patient could not afford it. But basic rule of antifungal therapy is that you have to obtain the accurate microbial diagnosis and decide if you have time before starting antifungal. There is always time to at least start the diagnosis or attempt for diagnosis simultaneously and interpret the microbiology result carefully, and do not treat, as I mentioned, candida in respiratory tract or candida in the urine. Consider host factor while selecting antifungal agent, and you should do therapeutic drug monitoring and use of antifungal judiciously so that it can improve the outcome, decrease the cost, and curb the increase in antifungal resistance. So you know that the strategy of antifungal is four. One is there is prophylaxis. This happened in high risk group when you have no symptoms but you are giving the drug, that is called prophylaxis. Empiric means when you have got symptoms like fever and you started because of the fever some drug, that is empiric therapy. Preemptive means when there is some biomarker or radiology suspecting the fungi, so that is preemptive, and documented, of course, we have got targeted therapy. Now, these are the areas where we have seen most of the misuse of antifungal happen. One is in case of prophylaxis. A lot of people do in low risk group even prophylaxis of antifungal. Either they don't give antifungal or they overdo the antifungal. That's both the scenario is there. Second, of course, in case of empiric therapy, and we don't know when to stop the therapy, that is very important. That's why prolongation of the therapy is a very important factor. As I mentioned already, that prophylaxis should be given in a cohort when there is only more than 10% which have been there. In case of empiric therapy, this is the empirical study which had shown in case of ICU that whether you give empiric therapy or not giving empiric therapy, the outcome, specifically the mortality, does not differ. Its only difference comes in case of the drug which have been given in that scenario. But this particular study, though it's a neutropenic group of patients where it had been studied, but this very important study, it had shown that the 275 patients in one arm where they have done or started giving therapy only when there is some amount of diagnostic factor is there, whether it is in case of galactomannan or beta-glucan which have been positive, or there is somewhere there is indication of fungal infection. Other group just the empirical therapy. And if you see that the difference wise in overall survival, there is no difference. There is no difference in case of the development of invasive fungal disease. Only thing is that there is less antifungal which have been used when we have given preemptive therapy. So preemptive therapy was safe for high risk neutropenic patient giving fluconazole as prophylaxis. This slide is very important. I always feel this slide because this slide shows green only when an RCT says when stop the therapy. Yellow means there are no RCT, but at least bigger studies are there which said what to be done. In case of orange means there is the retrospective studies are there, and red means really there is no small cases on which basis. You see, green signal is only in case of induction therapy in case of HIV having the cryptococcosis. This is the only thing where there is a good clinical trial said how long you should give the therapy. Nowhere you can see there is nothing which can be seen. Even in certain situation, there is uh, there is no data even. That is the black portion which have been shown, no data that is being present. So it shows that what is the problem in case of the duration of the antifungal therapy, whether it is prophylaxis or in case of induction therapy or in case of maintenance therapy. This slide I have shown you earlier also, that this shows that usually we used to believe that blood culture coming negative, you have to give therapy for 2 weeks more. Who has said it? Is there any study? It had come out now that there was a trial happened where they decided, the experts together, that we will take an outcome after 2 weeks. And from that, once it comes in a printed letter or printed word, it becomes a standard protocol and everybody started doing it. And this is now shown that there is, even with a lower duration of therapy, you can come out the outcome. Very recently, the European group has conducted a multicentric study which had shown by 10 days giving the therapy, there is no difference. I asked Dr. Oliver Corneli, who was conducting this study, why you jumped on only 10 days? Why not 7 days? He said, it is very difficult to get ethical clearance when it is stamped as 14 days. So we'll do a next study for 7 days. I said, you will have another paper. So you will get another New England Journal paper because of that. Even in case of the urinary tract infection, see, the duration of the therapy doesn't differ in case of the outcome which had been shown in this case. So practical consideration when you have to do for antifungal, you have to think about the host, you have to think about the drug which is against that particular agent, what is the agent, and site of infection is very important. Several of the antifungal don't penetrate the CNS, and that's very important. Like we all say kinocandin to be given in case of invasive candidiasis, but when there is eye infection or when there is CNS infection, well, even in case of the kidney, the kinocandin does not reach there. So you have to understand that part very clearly. Very few drugs. Tomorrow I will speak about the new antifungal so that you can know that there are some development which had come in case of penetration of the CNS. So coming now with this background knowledge, very shortly about the antifungal stewardship. First thing, what is stewardship? Stewardship is the responsible management of something entrusted on your care. And if you see in WHO, amongst the three pillars for integrated approach for healthcare management, one of the pillars is antimicrobial stewardship. So you cannot ignore the stewardship program now. Now, even in case of this, when WHO had identified 19 priority pathogens, they said that we need this stewardship because antifungal resistance is increasing. And of course, this study showed that during 2008 to 2018, the consumption of antifungal has gone tremendously up. So we need to do something in this area. Now you can say, friend, it's so difficult to have any stewardship program. I have got antimicrobial stewardship. Why not this can be included under it? After all, fungus is also a microbe. So it's better to include it. We said no. It should have a distinct. Why? First thing is that if you see all antimicrobial stewardship is directing only against bacteria, because fungus is always being neglected. They don't consider it's a very important one. Though very soon you will see more fungal infection rather than bacterial infection. That is going to happen very soon. Second important thing is that patient population is different. You know that where you are giving the antibacterial and antifungal, patient population is different. Limitation of the diagnosis, that's a very important factor. You may say a lot of things, but ultimately you may not be able to diagnose any antifungal. So if you cannot diagnose any antifungal, can you say that you will not give empiric therapy? So that challenge is always been there. Then antifungal susceptibility test is not like bacteria, which you say resistant is true resistant. It is still evolving, that is being there. Next is the complexity of the management of invasive fungal disease. It lacks consensus. And we lack expertise. How many expertise like Rajiv Smon is sitting here? So we need expertise in case of managing the fungal disease, and that's really very, very rare specimen in this country. Next, availability of the few class of antifungal. So you just cannot misuse antifungal. You have no scope in this regard. That is very important. And antifungal drugs are toxic, expensive. So all these factors, I hope I have made my case very clear to you that why we need separate antifungal stewardship from antimicrobial stewardship. So this antifungal stewardship requires the improvement in case of patients diagnosis, in case of improvement of patient environment, in case of optimal antifungal therapy, and of course overcoming the resistance that is there. So this is the 7 component which is being said as the core element in case of antimicrobial stewardship, and we have come to accept the same core element for antifungal stewardship. So one is the senior management leadership, next is the accountability responsibility, then available expertise in infection management, education training, other action for responsible antimicrobial use, monitoring and reporting feedback. But here, as I have already mentioned, in case of fungi, several challenges are there: limited knowledge, inadequate funding, overcrowding of the healthcare system, non-uniform access to the management or diagnosis, shortage of the trained manpower, all these factors making it problem. So first, look into this first core element: engagement of the senior management leadership to AFS. At least in case of Jacob, it's not a problem. The friendship, I have seen the management with Jacob, he can do anything so much easily. But it is not so much in case of the other institute. Here you have to convince them. Always management is cutting short. They always try to spend less and earn more. And in this scenario, if you have to convince them that you have to do antifungal stewardship, you have to really take out certain method for doing it. One of the method can be, suppose one of the hospital nearby who had done antifungal stewardship and performing better, you can take out their record, show the management. So that's one of the very important way in this. So you have to identify leader who can champion the cause. That is very important, and you have to do advocacy. That's very important here for promoting this. That is very important. Another point, I always feel that every hospital is going for accreditation. If I can convince in the accreditation process that there should be antifungal stewardship in the accreditation, then management have to do that stewardship program. That is one way of overcoming the difficulty in case of management engagement. Next is the accountability and responsibility. First, I have said what is the requirement, then what is the gap. And here the gap is, of course, the existing knowledge gap, lack of expertise. And recommendation which we can do is that develop team charter with defined responsibility and identify the creditable local expert who can really train the others. And here I would say that the telehealth now is doing a fantastic job. Suppose I have got a patient, this is the scenario. What do you think? I send it to Dr. Rajiv Suman, and Rajiv Suman says, "Oh, this is this one." So this is an expertise. I need not have to go to Pune to get this patient to be checked by Rajiv Suman. So this telehealth has come in a very big way. Many of the hospitals, like in case of PGI, we are running telehealth for the whole Punjab, and there are several patients who have been asked this way. That is very important. Then you have to develop a local guideline. That is very important if you have a local epidemiology. Now here, anywhere you do the studies, these two factors is very important, and the ID physicians who are sitting here, they can identify that most of the studies have shown that ID physician is a must for stewardship if you have to be successful. So they have at least an important job in case of your system which can be there. But what we are lacking is that ID trained pharmacist. I'm not sure where you have an ID trained pharmacist in your hospital, because that's very important. When you take the round, if you can have the pharmacist with you, he can really help you in case of your how to go for this aspect. Now, a lot of time you say that you have developed a guideline, but whether you are following the guideline or not, that is now by this defense scoring system that could be done. It had been developed for Candida score, it had been developed for Aspergillus score, Mucor score, these have been developed. And there is a study in Europe of 632 Candemia cases where it has shown that where they have followed the guideline, they had outcome is much better. So this is the way you can identify whether they are following the score or not. They are following the guideline or not. Next is that access to the appropriate diagnostic test. You know that we have a problem in case of this diagnosis. So first important thing is to simplify the diagnostic criteria. You need to develop some diagnostic criteria which can be employed in resource limiting environment. You know, this is such important that in case of chronic pulmonary aspergillosis, we met the experts together and we developed a guideline where we said that even CT is not there, how to go with a plain chest X-ray for this diagnosis of CPA. So these are the things which we need to do in case of going ahead. And we of course need the point of care test which is there. So here, as I have mentioned in the morning, that we sat together and tried to develop certainly when BDG is not there, how to go for it. Similarly, when galactomannan is not there, how to go for diagnosis. We have said that that is lateral flow assay can be included in it. Fourth component is the education and practical training. And here, when we have surveyed, we found 63% clinician had no formal training for fungal disease, and 68.9% responded mentioned lack of regular staff training. So that is the scenario of our all developing country in this Asian region. So what I try to say is that certain other method which you can do, that in case of the resident, you can put a pocket card. Say if this is the diagnosis, you go one by one this. So you develop bundle of care from this and that can be utilized in this. Recertification of the prescribers is now a very important issue. And here I think if we can include this management or training for the fungal disease, that would be important. All of you have gone through MBBS. Have you heard any antifungal management during your MBBS training? At least I have not heard anything about this. Rajiv, of course, is a very exceptional student. He in case of KM Hospital, from anatomy to medicine, every time he is the first. So such a brilliant guy should be different. But we all not heard about it. Even in case of microbiology, when I came from medicine to shifting from medicine to microbiology, I found that only bacteriology I have read. I have read one or two pages of virology. Of course, parasitology, KT Chatterjee is very good. We used to read that part. But mycology, I have not heard about it. And next 45 years, I am working on that area only. So this problem is always been there. You see, in Brazil, they have done simply in case of their healthcare record how to manage fungal disease, and that really improved their prescription by 80%. This is something simply they have not done an active training program, passively just added this list which have been there. Next is action aiming responsible antifungal use. That is very, very difficult and where you need to do. So here there lack of expert input, there is lack of even electronic health record that is being there. So here what you can do is that you have to do treatment bundle. That is the only way you can do. Handshake stewardship round can also be there, and daily coordination between clinician and mycologist or microbiologist there. Of course, if you can do, have a first thing is that we don't have internal formulary, and because of lack of internal formulary, can you stop any surgeon not prescribing antibiotic in any patient after doing the surgery? That is the major obstacle in case of government hospital. So there is a need of a internal formulary, so deciding about it. So here I have already said that sometimes in spite of that, you may not have the drug or patient cannot afford. So sometimes if you are using fluconazole instead of echinocandin, at least there are study support which have shown that even if you have got a susceptible species, there is no difference in case of mortality. And in case of your mucormycosis outbreak, COVID time, there was so much challenge was there. No antifungal drugs was available. I don't know, Kerala didn't possibly suffer so much of mucormycosis. It's really in Karnataka, in case of the Maharashtra, you suffered? Not so much. Not so much. We have thousands of cases. patients who are coming and mucor is coming from the nose like this. Honestly, their blood sugar is 1100. Have you heard blood sugar of 1100? Because they have been given steroid for months together and at a 30 milligram instead of 5 to 6 milligram dexa. So then mucor is coming to the nose like this. And there were so many cases, ENT surgeons were operating 2 OT dedicated for them for 24 hours. So this is the scenario which happened. So, but the antifungal drugs were not there. So government had made me as the chief national expert in it. So I contacted Rajiv and my fungal infection study forum group and said what to be done. So we developed this protocol where we said that if lipid proportion is not available, do amputation, be deoxycholate. If this choline is not available, we can go for isavuconazole or posaconazole. And even nothing is available, never you have heard itraconazole to treat mucormycosis, never you have heard. But what we found that in vitro data shows there is some good effect. So I had contacted European experts, USA experts, and have a meeting with them, say, can we recommend it? And ultimately, with all the data which you have provided, they have allowed it. And we have treated a lot of patients with just itraconazole. But our bad luck is that they could not have a paper out of it so that at least it could be really authenticated for the people. That was a very really bad luck for all of us. Bundle of care. As I've said, this is the way you can go for it. This is not very far. Your Amrita Institute did a bundle of care in management of Candida. And if you see after this bundle of care, the development, their appropriateness increases, their mortality has come down in case of invasive candidiasis. So I am saying you this bundle of care is very important issue which is there. Sixth point is the monitoring and surveillance. Here you need the surveillance, but it is not there. So here always I say that can you do improve the infection control practice? At least if you have not no money, at least you minimize the fungal infection or bacterial infection development, improve hand hygiene. And another thing is that fungi is coming in the environment. So here what I suggest is that in ICU patient, all of them, if you don't have HEPA filter, ask them only cotton mask at least. You can reduce it. Nowadays, nobody minds to have the mask continuously. We are all fond of having masks with us, so that can be easily being done. And of course, when you don't have TDM, then possibly you have to think about the drugs which can be given injectable, and where there is less interaction drug that to be need to look into. Another important thing, microbiologists sitting here, I request them please develop a technique like bacteria, a plate diffusion technique for antifungal susceptibility testing. That would be much easier for this. Lastly, that is the reporting and feedback. Here again, I would say if you don't have so much of data for surveillance, at least do the point surveillance. Suddenly one day you decide, go around the hospital, how much is the misuse, you see about it, and you just inform that particular group of clinicians that this is the area where you are misusing this antifungal. That would really help. So lastly, what I try to say is that when you are giving any antifungal, these are the questions you must answer. Does this patient need antifungal? Does this antifungal cover the suspected fungi which I am thinking? Is it the first option recommended in case of the guideline? Is the dosage correct which I am giving according to the body weight, liver and renal function? Is there any chance of drug interaction? Is the antifungal adjusted after microbiology result? Is the intravenous drug is required or we can switch to oral drug? Is the duration of therapy correct according to the guideline? If you can follow all these things, you will be successful in managing the antifungal stewardship. Thank you very much for your time. Thank you. So many people are still sitting. I am very surprised. Oh, bahar barish ho raha hai. Oh my God, that's why you are sitting here. That's okay. That helped me in case of at least promoting antifungal stewardship. Any question or any ideas, you can give it to me.
You showed a paper on research of UK with Canada. Why do they treat UK and Canada?
Why did
They treat Canada in the urine.
Candida?
In the urine.
Ah.
You showed a slide where you showed.
No, I said there are patients. There is a Candida UTI. You cannot say that Candida doesn't produce UTI, but Candida colonization of the urinary tract is more common rather than producing urinary tract infection. There is a group of patients where there is Candida UTI. You produce put the stains and all those where there is. It's not. Please, by my other presentation, don't go away that there is nothing called Candida urinary tract infection. Of course, there is Candida urinary tract infection, but in case of Candida in respiratory tract, I would not accept any isolation from the whether it is BL sample or any way to link it to the pulmonary candidiasis. You know, people say the patient is completely cell count is zero. There is no neutrophil, and the patient has got confluent candida in the BL sample. How can you say that this patient don't have and repeatedly isolated? I said, my dear friend, you can give antifungal because it is your patient. I cannot prevent it, but don't take the help of my this factor that there is candida in the respiratory tract. So candida in respiratory tract should be completely ignored. That's nothing in that way. But of course, candida can produce urinary tract infection. Like if you have got a stenting had been done, where there can be certain scenario in case of premature babies where you can have candida UTI. In case of the neutropenic patient, also sometimes you can have this candida UTI infection, but that's very less. In case of immunocompetent patient, mostly what it happens, any patient with catheter, you will definitely, you see that paper which have been yesterday in the panel discussion had been shown, that study that showing the first isolation or the commonest isolation is candida in case of the urine. That is absolutely candida colonization, because any patient having got at least 2 days of Foley's catheter, you may get candida in the catheter unit. So you just change the catheter, your this candida will go. There is no treatment required. No, you should not, because there is a challenge happened, because you know there is a this particular clinical rule came where they said that you have this colonization in respiratory tract in case of GI tract, in this on that basis you do about this aspect. But I say that in case of India, especially in ICU, 95% patients have got candida in respiratory tract or in case of the GI tract. So then give 95% patient all antifungal. That is not the correct thing, no? So it's not helping the clinician. Yeah, that's true. That's true. And also, don't they do the counting in case of the urine? There is a lot of people try to do the counting. You know, there is people think that this has got money because you are giving a report with candida count, so you can charge more. But this is useless for the patient management. Nothing is there. No other question? So can we end the day? No? Oh my dear.
Thank you so much, sir, for that excellent presentation.
Now, let's move on to the IDQ's Konbenega ID Charm. It's time to add a bit of fun and excitement to the evening with our interactive section titled IDQ's Konbenega ID Charm. This promises to be an entertaining and educational challenge that will test your knowledge in infectious disease, Leading this section is our quiz master, Dr. Neto George. Dr. Neto, we welcome you.
It's going to be a cohort-based online quiz. So not only the correct answer matters, the faster you respond, you get more points. That also matters. How many of you use Kahoot previously? only കാര്യമൊന്നുമല്ല. Just go to Kahoot site. It will give you a code number. You just enter that.